Live now.
Okay, good morning everyone. You're very welcome to the public board meeting of Kettering General Hospital. We're going to start with a volunteer story. We normally start with a patient story, but on this occasion we want to start with a volunteer story. I think Mark and Leanne, or between you, are introducing this.
Yeah, good morning. Thank you very much, Alan. Yes, so I'm introducing today Claire Jennings' story, a volunteer who's been working in our We Care Cafe, and so thanks to James for actually capturing this on video. It's a really great story. I think we can't imagine looking back over a year ago where we'd be without the We Care Cafe and all the volunteers that have been supporting us through that. So I thought many thanks to all those that have been involved. And when you hear Claire's story, you'll understand what an impact it's had on our volunteers, but also on our staff. Thank you, Mark, over to you.
Thank you, Leanne. So I just wish to echo Leanne's point, particularly in relation to the We Care Cafe, but I'm really pleased to be able to share this story of Claire's today and indeed this morning. The volunteers in our organisation and indeed across our group play such a vital role, and we're going to hear that, and a huge versatility in the roles in which they play in supporting both our patients and indeed, as we'll hear today, in terms of our staff as well. It's a big feature in our people plan, which is coming up later in the agenda today, in terms of really emphasising the volunteer sector and how we can really develop that service moving forward as a group, creating even more versatility and more opportunities for people to come and volunteer within our services. But without further ado, if it's okay, Kieran, I would hand over to Claire to share her story.
So a little bit about what I've been doing in the organisation. I've volunteered at Kettering General for about 8 years, mainly in the chaplaincy department, and now it's called the Pastoral and Spiritual Care team. I volunteered with them for about 8 years, and that was great. I spent a lot of time on the wards talking to various patients. I was mainly in the Oakley and CCU unit, and it was just lovely to spend time with patients and talk to them and hold their hands, as we were allowed to back then, and just talk with them and pray with them if that's what they needed or wanted, and also spend time with the staff on the unit there as well. More recently, in the last 12 months since COVID, I've been working in the We Care Cafe. And that's I do that twice a week, a couple of shifts, and what an experience that has been, getting to know people, them getting to know me, spending time with them, so much so now that people know when I'm there and are looking out for me when they want to just have a bit of a laugh, or just to even talk about some things that have cropped up in their lives since they've been spending time with COVID and getting to live their life with that. And it's just nice to be able to come and to share my time with these people that are spending their time, really, helping out, making people better, just enabling the hospital to work in a better way. And I just come and make sure that they've got drinks and biscuits and being looked after as much as I can. And people have come and shared stories about life inside the hospital, but also what's going on in their life outside the hospital. And it's lovely to just be there for them. And everybody comes down, from porters to housekeeping staff to consultants. And it's just great. And in there, with it being in the Prince William Education Centre, I've got to know the library team really well. And I'd say I'm probably quite good friends with them as well now, so that's been lovely. I've also helped out in the vaccination hub, and I absolutely loved it. It was busy, it was a bit crazy at times, there were people coming in and out, but what a sense of achievement to know that I was part of the team that managed to get all those people vaccinated, and to see the look of delight on people's faces when they knew that they were on their journey to get a vaccine, to become safe in the new world. And it was just a lovely experience to be part of that. And what's really exciting is that it's opening again next week, and I've been asked if I can help again, so I'm thrilled to bits about that. And then in the last couple of weeks I've been helping out with Project Wingman, which is when cabin crew from the airlines have been furloughed, and they've been coming into the hospital to go around the wards and make drinks and serve sweet treats to the staff who've been too busy to get their own drinks. And so we arrive on the ward with the cabin crew all in their nice uniforms and everything, BA and TUI and all the cabin crew. And to know that the staff who are busy, who are crazily looking after everybody else, to see their faces when we say we'd like to make you a drink, it's just so nice to see that they feel that they're appreciated. And to be part of that is, again, it's been a privilege actually. And so I say in the last 12 months being a volunteer has been a fulfilling thing for me. I wouldn't have wanted to sit at home knowing that I could have been helping and didn't. But I have been given the opportunity to come here to share some of the skills that I've got, and even if it's just a smile with my eyes, because you can't smile with your mouth behind your mask, and to have a listening ear, but to provide some sort of support. In my head, it's been fulfilling, it's been a privilege, and I've loved every minute of it.
So hopefully that story resonates with everyone as it does with me. It's a, what can I say apart from a massive thank you and to Claire and for sharing her story, and indeed for everything that she's helped us with over the last 12 months. It's truly inspirational. And I should also at this point mention a big thank you to the volunteer team. And I say team as if we think it's in a lot of people, but Christine and Neil and Karen, who've been supporting our volunteers and coordinating them to help support our patients and our staff. Thank you, Alan.
Thanks very much, Mark. We talked, many of you will remember, at the Christmas event for governors some 15 months ago about the need and the importance of increasing the number of governors and increasing the roles they played. And there was a classic example of what our volunteers, increasing the number of volunteers rather, and there was a classic example of what volunteers can and do. So that was remarkably impressive. I took the opportunity yesterday of sitting in a garden with some colleagues, and the conversation turned to what made a difference for staff. And the two things I talked about was the We Care Cafe and the Operation Wingman, although I have to say I forgot what it was called. But those two things just seemed to make them feel they were treated rather specially, and so they should be. So thank you very much for that. Thank you, everybody. Thank you for the volunteers. Any comments at all on that from anybody else? Before I move on? No, just a few clapping hands symbols. Thank you, Richard. Okay, so apologies. We have apologies from Professor Chilton. Dr. Imtiaz Rabia is with us today as his deputy. Any other apologies that I'm unaware of, Richard? Either Richard?
Yes, from our Associate Non-Exec Director, Lynn Hinnigan, Alan. Thank you.
Okay, thank you for that. And we'd like to welcome Debbie Needham, who's with us today as our first public board meeting as our Hospital Chief Exec Officer. Debbie, you're very welcome. Although it seems strange to be welcoming you into Kettering. And also welcoming Faye Gordon. Where's Faye? There's Faye, and my screen at the bottom anyway, who's our Interim Chief Operating Officer. You're very welcome. And I hope you enjoy working under pressure, Faye, because looking at the planning guidance and the recovery metrics and so on, it's going to be a demanding interim period, to say the least. So you're both very welcome. Minutes of the meeting held on the 29th of January. Are you happy they're a fair record of the event? Richard, apps.
Thanks, Alan. I think we have just got on the attendance record. Ian Roddis was in attendance. I think we just got his job title a little bit wrong. I think if Andy can help me, he was interim digital director, or acting digital director, not CDIO.
Yeah, that's correct, Richard.
That's altering as well, isn't it? But we'll come to that later on in the agenda. Anything else at all in the minutes? No, not seeing anything. Okay, thank you. And the action log, both green, both closed. Are you happy with that? Yeah, good. Okay, so briefly from me, just to put on record in public that we've now made an appointment of the Hospital Chief Exec post at Northampton General. thank you for your contribution, Alice, as joint chair of the Collaboration Programme Committee, and we've appointed Heidi Smote. Some of you might know Heidi. Heidi is the Deputy Chief Inspector of Hospitals for the Care Quality Commission and responsible for the Midlands region. So Heidi, no pressure on achieving an outstanding rating for Northampton General, I'm sure. But we were delighted with the appointment, and all of the hospital reps on the committee were unanimous in supporting Heidi's appointment. And I was just talking to Simon earlier, and as he reminded me about his own arrival, regulators tend to have very long waiting periods, notice periods, so Heidi is unlikely to be with us before September, which is, unfortunate, but that's the way it is. We're also in a position, though, to tell people we appointed a group communications director, who's a lady called Teresa Latang. Mark, have I pronounced that correctly? Latang? Yes, I have. Jolly good. Thangue, so it is slightly challenging. And she comes to us as from being Director of Communications, Head of Communications with the City of London Police, who are not without their tricky communications issues over the last few years. So we welcome her, and she's joining us on the first week in June. I think that's all there is from me. So unless anybody wants to comment on that, which I don't think they are, then we'll go straight to your report, Simon. Oh, just to say, I think it's worth noting that the report, that Simon's report, and then moving on to Debbie's report as a hospital chief exec, beginning to see an exercise here in who does what between the group chief exec and the hospital chief exec. And obviously that's the beginnings of a conversation. We don't have an answer to this yet. And we Simon's talking to all the team, and I'm talking to people about how this will work. But I think it's just an interesting exercise in beginning to have that conversation. What's in Simon's report, what's in Debbie's report, and non-execs in particular just need to think in the future about, what do I bring Debbie up for? What do I bring Simon up for? And that will play out as well through the CIO role, through the finance director role. What do we bring Anil about? What do we bring the group finance director, and so on and so forth, HR as well. So just the beginnings of that conversation. We're not going to bottom that out, but just a bit of worthy reflection on that. And I know then we'll be moving on to talk about the planning guidance, which has come out. You should all have had a copy of it, and that will be the guiding bit of policy document for the coming year, certainly. So, sorry, Simon, for that false start. Over to you, please.
Thanks, Alan. As you said, 4 things to talk about this morning, in addition to the report that is tabled. So the first is we have now got the planning guidance and financial settlement for the first half of this year. And as you said, Alan, we'll spend some time today considering the position that we as a group find ourselves in as we move into that first half of the year. The financial framework, which underpins the operational ask of us, looks remarkably similar to that which we left this year just gone. So we are going to be continuing in block arrangements for at least the first half of the year. And at the moment, that's gives us stability and certainty, but it also means that, unlike other years, we are unable to put forward a plan for the entire year. On the operational ask, colleagues will have had the chance to start considering the challenges that are posed in there. Nationally, we face a position in waiting list terms that hasn't been seen in the NHS since 2007, and that is a waiting list of very significant proportions nationally, with a very significant number, sadly, of 52-week waits. And very simply, our operational challenge now is to get back as quickly as we can to some form of normality and restoring services that have either had to have been paused or delayed or didn't happen because of COVID. In particular, there will be an ask around focusing on long waits where we have them, and we will talk about that during the course of our discussions today, and also making sure that those patients who have cancer get the treatment that they need. So some really important deliberations around getting services back to normal. Getting back to normal, of course, is much more complicated this year. And the second item, one of the items on our agenda, and the second item I wanted to highlight in my comments today is, of course, the planning guidance pays attention not only to the need to restore services, but also to the fact that in restoring services, we have to pay attention to how our people are and the rate at which they can work. I have already made clear in my report the enormous debt of gratitude we owe to our staff as we exit wave 2 of COVID, and we are now mostly back to normal. It seems almost inadequate now to say thank you, but obviously the report says that, and I make no apology for saying thank you again here. But in actual fact, one of the biggest ways in which we can thank our staff is by taking care of them as we go into this phase of restoration and recovery. And so the debate that we have today on the people plan, I think, is going to be a really important debate going forward, because just as we've got to push ourselves to restore and recover services as fast as we possibly can, because that's what we would all want it for us, we've got to do so in a way that takes our staff with us and actually just makes them feel we're not just asking more and more and more and more. And so I really want us to spend some good quality time on the people plan and saying, do we feel that we pushed ourselves as hard as we can on that? Just as we have to push ourselves as hard as we can on recovering services, have we pushed ourselves as hard as we can on having the very best people plan that we can? Another key plank of recovery that we will talk about today, but also that has been going great guns during COVID, is of course the digital strategy. Everybody will know by now that we've got hugely ambitious digital plans, and one of the biggest achievements in actual fact of that digital plan has been that it's kept going throughout COVID. But even more so, as we move into recovery, our digital journey will support some of the aspirations that we have. Our ability to understand our waiting lists and our ability to understand what's going on in those waiting lists will now be at a premium. So our knowledge management, our business intelligence function is really going to come at a premium this year. And I know that Andy will spend some time talking about that later on in the agenda today. Finally, I wanted to just drop on the Quality Summit that is in the report at the end. I thought this was a really excellent example of how people can come together and reflect and learn on some really difficult things. One of the things that I thought was most impressive about that was that people came together across the group. Traditionally, if that sort of thing had happened, it would be in the purview of a hospital to do that, and it would be a relatively closed conversation within that hospital community. And one of the really, it's never nice to have to talk about those sorts of incidents, but one of the positives about it was, in actual fact, this was learning that came across the group and people's reflections came across the group. And I'll share, just by way of conclusion, the message that the staff there asked me to convey when I asked them the question, what would you like me to say to the boards on your behalf? They said, please don't push us too hard as we go into the year ahead. Please do pause and take care of us, because in actual fact, the context from which they're coming has been, for many of them, the most difficult period of their entire careers. And it's easy for us to know that, but it's hard sometimes to internalize that and then really live it in what we actually do. So as we go into our debates today, I would ask us all to hold that thought in our heads and in our hearts, because they are the people who will be helping us deliver the things that I have talked about. So that's everything I would like to say, Alan. Happy to take any questions.
Okay, thank you very much. We will obviously, through the committee cycle and coming back to our board in May, the big question is, what is the balance between recovery for our patients and recovery for our staff? And that's the question we have to find an answer to, and what we're asking people to do, which we will do over the next period of time. Anybody want to comment on anything in there? The Quality Summit did have some 150 odd people at it, so it was the exact opposite of keeping quiet about something. Chris.
Alan, if I could just comment on the Quality Summit. I've been dealing with Never events in my former life for many years and attended a number of Quality Summits. This was by far the most impressive I have attended, and I reinforce everything Simon said about the summit. The learning from it and the coming together was really, really impressive. And I would say thank you to all the staff who participated in it.
Thank you, Chris. I think everybody who was there had very similar sentiments. Okay, thank you very much. Debbie, Mrs. Hospital Chief Exec Officer, you're on.
Thank you, Chair. So yeah, this is my first Kettering Trust Board in public. So I'd just like to start, first of all, by saying thank you. Thank you to the staff in the organisation, but mostly thank you to the executive team for welcoming me to Kettering. I've spent a fair amount of time in the last 2 weeks, so I'm now in my 3rd week. I've spent a fair amount of time going around and meeting people and trying to find my way around the hospital. Some of you will know that I've got lost on several occasions. So thinking about the agenda today, I've been really pleased to hear that the staff survey from last year has improved in 5 areas, as well as the overall response rate increasing by 7%. Now, clearly we have got some work to do, and that work, especially on teams, how teams work together, immediate managers, and how we move forward as part of the group, but as an inclusive organisation. But really pleasing to see that our staff, there's an increase in our staff who would recommend KGH as a place to work. That's really good to see, and that's something that we need to harness and work on to make even better. Just moving on to emergency activity. So that started to increase, and I expect that that increase will continue as we move along the roadmap out of lockdown. A&E has started to get busy. We've started to see A&E busy again on Mondays. And Faye will come on to talk about A&E and the activity, but quite a lot of work is being done to make sure that we have a smoother path throughout the week. The A&E team, who I've met some of, have recently met with the CQC, and that was following the last inspection. I understand that the meeting that they had with the CQC was really positive, and the actions which they've put into place, such as increased capacity to make sure that we are not reverse queuing and splitting out the children's area, for example, really positive and quite good feedback from the CQC on that. As Simon has noted, health and well-being of our staff is definitely a concern. Mental health of our staff is a concern going forward. I'm pleased to see in the recent priorities and operational planning guidance that's come out that health and well-being for staff is taking priority, along with restarting elective work. As it's already been noted, it's really important that we maintain safety as we start to reset our services, because we've got to do things safely, but equally we do have patients who need to be treated. So this is going to be a fine balance for our staff. The expectation with reset is that we, for those who haven't had a look at the guidance as yet, is that we undertake at least 70% of the 2019-20 baseline activity in April. This is for our elective patients. The expectation is that we will then increase that by 5% each month up to July, where we're expected to be at 85% of the 2019-20 baseline. This is a tough challenge for us. And as you said earlier, we will be bringing to the next board how we are planning to do that, and obviously the actions that we've taken, because we'll be in May at that point. We also need to be delivering 25% of our outpatients virtually, which again is the right thing to do, because COVID is still there in the community. We know that we've got high case rates, certainly in the north of our county. So we've still got to really play our part here. And outpatients virtually from the patient's own home, definitely the right way to go. So I'll be focusing the team on making sure that we don't only deliver 25%, we really increase that higher. So we'll be playing our part with the system in terms of our activity, finance and workforce plan, which will need to be submitted in draft in May and then finalised in June. I'd just like to end by giving you a brief update on COVID patients. So today we've got 14 patients in our organisation who are COVID positive. 3 of those are being cared for in critical care. This is really, really good news. Not good news that they're in critical care, but good news when you look at the numbers that I reported in my report, but also where we were last month and the month before and through winter. So I think my main message really is we've still got to play our part as we start to come out of lockdown. But I'll just end by saying a final thank you to our staff for all that they are doing in terms of looking after each other and also looking after our patients. And I'll stop there, Chair. Thank you.
Okay, any comments on anything there at all? No, I'm not seeing anything. Okay, thank you very much. Thank you, Debbie. The IGR, the Integrated Governance Report, we'll be taking that in the normal way. Just in passing, our IGR, which a lot of people have worked on over the last, I don't know how long, since we had our visit from Sam Riley from NHSI and started to talk about a different way of showing our performance. But we're now being held up as a national exemplar, and there was a national event last week with over 130 attendances from other trusts, the CQC, NHS, E&I, to hear the inverted commas Kettering story about how we started to produce this now national exemplar IGR report. And Simon was telling me I had a phone call from Guys and Tommies asking how to do it. Now, I've always wanted to have a phone call from Guys and Tommies asking how to do something. So I think that's a terrific achievement. So well done to the team who put that together. And I know it's a lot of work in both digital and in the directorates and in Richard's empire. So thank you, everybody, and well done for that. So over to the actual report now. I think you're going first, Leanne?
I am. Thank you very much, Chair. Yes, thank you. So just in terms of the quality aspects of the IGR and how they link to, for example, workforce and staffing. So as you can see, we've kind of held steady really with our complaints management, and we know we've got further work to do to turn that round. We have had a lot of people that have been shielding who have been helping to support the turnaround of complaints, but we need to see a sustainable change in that. We did have a Never event in February. Unfortunately, a patient disconnected themselves from their oxygen supply, put themselves on an oxygen cylinder, went to the bathroom, came back and then reconnected themselves to the air supply. That was identified and we did a swarm, so there's no other points around that patients can do that with. Regrettably, the patient did die, but not as a direct consequence of that. It was several days later. So we're obviously looking back through all our HSE warnings and CAS alerts, etc., just to make sure we haven't missed anything in relation to that. Falls remains still our area of concern, and we've talked a lot about this at Quality and Safety Committee, and particularly over in February and November and February were our hot points in relation to the number of falls that we had with harm. And what it appears from doing all the work, again using SPC and plot the dots, etc., is that we can see that when activity and acuity is high, that's when we tend to get some of our falls. There's been lots of questions around whether it's directly related to staffing. Yes, we've had some concerns with our staffing, but they do not seem directly comparable at the moment. But we are looking into that and conducting a piece of research just to make sure we're not missing anything. So there's a lot of focus on falls. We've had 2 falls summits internally to this date, and there are a few things that we know we can act on very quickly, such as, for example, using EPMA as a means of highlighting patients that are at high falls risk and making sure their medication gets reviewed, that bed rail usage, etc., is as best as it can be. So there are a few things that have been highlighted from that. I'm pleased to report that in March we haven't seen the same number of falls with harm that we've had previously in February. So that's really good work. In terms of the staffing element of this, and again, we've talked a lot at this Quality and Safety Committee and also Workforce or People Committee. We have at any one time, from a nursing workforce perspective, about 30% of our staff that are unavailable on any roster. Now, that could be related to the clinically extremely vulnerable list, which has gone up a little lately. It could be shielding. It could be the fact that we've got a lot of overseas staff and new starters that have joined the rosters, but they're not logged into the roster to say that they're registered, for example. So there are many aspects to that. So we work, as you know, we work tirelessly to make sure we share staff across the organisation the best we can be, as we can at any one time, and that takes a monumental effort, but that's what we do all the time. So staffing remains a concern. Hopefully now some of our shielders will come back. That will help us. We have been really successful in relation to our staffing and recruitment and overseas recruitment, and we're now on cohorts 8 and 9 from overseas. And we also have now 50 nursing students from across the country who want to come and work at Kettering when they qualify because of our preceptorship program. So I think there's lots of hope for that for the future. So I'm confident that we can address those issues. The Skylark ward, you'll know, was swapped with Harrod and Sea ward for the winter to make sure we had a good enough oxygen supply for our respiratory patients. They successfully moved back last week. And I think we need to thank both sets of teams for all the work they put in place to make that happen swiftly and smoothly. You know, both times either going one way and then back the other way took only a couple of days. So it's quite incredible how the teams have managed to maintain patient safety, maintain our staffing, and also make those moves. So that's another big thanks to the team. And Debbie's already mentioned the CQC interview that our ED team had a couple of weeks, well, about a month ago now, reflecting back over a year of progress and quality improvement in the emergency department, and the confidence and the assurance that the CQC reported back was really testament to the team. So they've had a lovely big cake and a big thank you from us, because it's been a big, hard, long journey. What we've got to make sure we do is not take our eye off the ball when we're resetting and all those types of things. And the other point to note on the CQC perspective is Richard Fay and I had an interview with CQC regarding in terms of their new inspection regime, which was about an hour and a half, 2 hours, focused on well-led safety aspects of COVID, etc. So unfortunately, we don't get any feedback from that, and there's no rating change, but ultimately it might inform whether or not they do a boots on the ground inspection in the future. Happy to take any questions. Thank you.
Anything at all on that, Chris, as chair?
Yeah, thank you, Alan. A couple of things. So first of all, COVID, the Quality and Safety Committee has met on 2 occasions, the 23rd of February and the 22nd of March. I just wanted to repeat to the board the assurance that we've received concerning the management of COVID patients within the hospital, particularly 2 aspects. One is that all the deaths from COVID have been reviewed by the medical examiner system, and on occasion, lessons have been learned from that. And the second is the level of infection prevention and control within the hospital, and all of those reports, both provided by both Leanne and Manjula. Leanne has already commented on the staff availability issue. We've discussed that at the committee on both occasions at considerable length. And there may be some issues that have been further complicated by the staff shielding letter that came out from the NHS executive. We've also discussed the falls issue and want to investigate the timeline between SIs, staffing and activity, and Leanne has got that work in hand. And finally, we just need to mention the Ockenden report concerning maternity services, a national report, and confirm to the board that there is a high level of compliance with the recommendations of the Ockenden report at KGH, other than weekend obstetric ward rounds, the level of those ward rounds, and there needs to be some additional recruitment, and that is in hand. Finally, the Never event that Leanne mentioned was discussed, but we're awaiting the final report on that. Thank you, Alan.
Okay, thank you. Anything at all on that part of the report? No, not seeing anything. No hands up. Okay. PF&R on the operations side. Faye, and then I'm hoping, in the absence of Damien, that Lisa can talk about it from a non-exec perspective. So, Faye.
Okay, thank you. So just a few things to draw your attention to. Obviously, RTT, we, as Simon's already mentioned, is a national pressure, but as an organisation, we are doing pretty well. So current position is 73.23%. As an organisation, we haven't had any 52-week breaches until January. The team are immensely disappointed about that, but unfortunately, you know, with everything that was put into place, we weren't able to avoid them. However, we have a very clear trajectory to get back on track. And in February, we had 60 breaches. We will have another 100 in March, and then our plan is to get back on track come May. Our plan very much revolves around ITU and our staff being able to move back to theatres. I'm pleased to say that of the 30 that were working in ITU, 20 have already returned back to theatres, which has meant we've been able to switch on more capacity, which has meant that we will be able to deliver our trajectory. Just in terms of the staff, just to mention that the staff have had a period of debrief and reintroduction before they went back into their main team. So in terms of where we're heading, as I say, we hope to deliver our 52-week plan by the end of May. And the team are working on a further plan to reduce our waiting times to 40 weeks by September. We currently have 286 patients over 40 weeks, so the team feel that is pretty doable. In terms of diagnostics, again, significant improvements month on month, so really good news story. Our position was 94.9% in February. We had hoped to be able to deliver the target in March, but unfortunately we've had some issues with a CT scanner at the Woodlands at the last moment, which has meant that we won't be able to meet that target. 200 patients have needed to be deferred until to the end of the month and into the early next month. All of them, I'm pleased to say, have dates, and we will be back on track to meet that target in April. From a cancer perspective, as you will be aware, last month we were moving in the right direction. This month our performance is 68.3%, which is a dip on last month. The reason for that is that we're treating our legacy patients. So we will expect to see our performance dip as we deal with those patients. The good news story around this is that at the beginning of February, we had 117 patients who were legacy, if you like, patients that are waiting to be either diagnosed or treated, and we now have reduced that to 57. So we're absolutely moving in the right direction. Our legacy patients consist of patients that are either waiting still for investigations and have delayed because of their choice, and some patients because they're waiting for treatment in our tertiary centres. But we're working hard with our partners to address that. But from a cancer point of view, we are moving in the right direction. Super stranded is also something I'd just like to mention. We have a very ambitious target of getting to 38 patients, or no more than 38 patients, and it is ambitious, but we really feel that that's where we need to aim to, and so we will continue to work really hard to achieve that target. In February, we were at 74 patients, which I'd just like to highlight a significant improvement on where we were this time last year. So we're moving in the right direction, but we absolutely have challenges around meeting that target. But we all feel that this is the right thing to do for our patients. So we'll continue to work with our partners and our nurses to achieve that. Some of the challenges around meeting that target are internal and some external, but we've got some very senior nurses leading on this element, and we will continue to really focus our attentions. And 2 weeks ago, we had a MAID event, so a multi-agency event with our partners, recognising that we were coming close to Easter and that our trajectory wasn't quite going in the right direction. And I'm pleased to say that 3 of our patients who were with us for over 100 days were all discharged. So finally, in terms of ambulance handovers, again, just to say that, you know, if you look at our performance in the past, you can see that the teams have made significant improvements in our performance. Unfortunately, we did have 8 breaches in February. All of these breaches occurred on one particular day, and the main reasons were around staffing, inflow, acuity. We continue to validate every single breach to make sure that we have no harm has come to those patients, and we also validate and ensure we learn from the situation that has occurred on that day, and the teams in ED always have a debrief the following day to address anything that's immediate. Just to highlight, as Debbie said earlier, activity is starting to heat up in ED. We are seeing more attendances. Ambulance conveyances are slowly growing. Our conversion rate continues to sit around 50%. But what is really good in ED is the fact that we are continuing to use other avenues other than ED. So there's some really good work going on in terms of streaming. And SDEC activity has increased from 18 to 25% in the last 2 months, which is really good news. So they're the things that I would just like to draw to your attention. Thank you.
Lisa, anything on that?
No, I think covered a lot. I think from an operational point of view, really just a focus on the restart was one of the key areas of the committee meeting. You know, reflecting a lot of the comments that have already been said about how do we gear ourselves up to tackle the backlog in an efficient manner without putting undue stress on the employees. So trying to balance that, the demand of the patient with the employees. But otherwise, from an operational point of view, really the other thing we're really focusing on is how do we ensure that the positives that we've experienced during this terrible pandemic really get embedded into the working of the hospital. And I think the other final thing to point is we held our first joint PF&L committee this period, which I know gets ratified later on in the committee. But again, it gave us the first insight into putting KGH's metrics alongside NGH's metrics, and really some interesting insights. Not that we have the answers yet, but interesting to see some metrics moving in the same direction and others moving in the opposite direction. So really just illustrating how the power of the group will drive better insight and hopefully drive efficiencies over time.
Excellent, thank you very much. Just sorry to drop a question on you, Faye, but we had a long conversation at the NGH board about the number of ambulance arrivals who were discharged directly from ED. Do you have that percentage in your head?
Yeah, it's 50%. 50%.
So 50% of patients who choose or are brought by ambulance end up going straight back out again to some other service or to home. It's an interesting reflection on behaviours of our patients and the relationship and the processes and the protocols of the ambulance service for that. Anybody else? Debbie?
Yeah, thanks, Chair. Probably start there, actually. So we have a high number of patients who walk into the organisation as well, who perhaps could go elsewhere. We know that we've got an urgent care centre up the road, so I'm planning to do some work with Faye to make sure that we are diverting patients to the right places. And I think there is something then about the public starting to know where to go. So it will be a slow process, but we do need to start to turn people away at A&E if they do not need us and stream them out to Corby, for example. I think the second thing is around stranded and super stranded. So we already know that we have got a gap in our capacity going into next winter, and I'm hoping that we'll be able to bring the winter plan to our next board meeting. So it's really important that we start to do more work on reducing our super stranded and stranded. And of course, some of that is within our gift, but some is not. And then cancer. So I am concerned about the high number of legacy patients, and especially those who have not yet been diagnosed. And again, some of that is within our gift. I know that Faye has spoke about some of it not being within our gift, but some of it is. So Faye and I over the last week have been discussing how we might put in place some regular senior input and some supportive challenge with those patients who are over 62 days. And just to say thank you to Faye, that was the first MAID event that Faye had run in her career, and it was a real success with a lot of discharges. So thanks, Faye, and well done.
Thank you. Lisa. Ellen.
Thank you. It was just a question really about the national initiative of, I'm going to get it the right way around, talk before you walk. So NHS 111, the policy shift that says actually people should be phoning and booking slots now into A&E. I just wondered where that had got to. I know COVID kind of took over, but.
Yeah, so actually, we spent quite a lot of time during COVID putting that into place. But I think what we've noticed certainly over the last few weeks, that seems to have gone out of the window. So we are basically reconvening our Think 11 and looking to see what we can do. One of the things that we were asked not to do was to turn people away at the door if they hadn't rang Think 111. All other organisations had done that, but we were asked not to do that locally in terms of putting pressure on Think 111. But I think that now's the time to reassess that situation. So we will be, as I say, reigniting our Think 111 meetings, and we will start to look how we take that to the next level. Because as Debbie said, the activity is heightening up. The last couple of weeks we've seen significant numbers in our ED, and they've coped phenomenally. But the majority have been minor patients that could have gone elsewhere. So that's definitely an area of focus that we need to have.
Okay, presumably with a fair bit of communication to the public and other services behind that, telling them they need to phone and make an appointment in ED. It sounds really counterintuitive, but it does work, of course. Leanne, that's a new hand, isn't it, Leanne?
It is a new hand, yeah. Thank you. That's a new hand, thank you. Yeah. So just on the back of that, I know there's been some national guidance in terms of if you have a COVID vaccine and you have a headache, to seek help for your headache and potentially CT scan. It's been discussed at the System Clinical Leaders Forums. So I don't know, but it would be worth us having a look at, see how many patients have come to minors as a consequence of that. Because we, both Faye and I and Deb have recognised over the last few weeks the phenomenal amount, particularly on a Monday, it appears, is going back to pre-winter and winter levels.
Okay, Lisa, your hand still up?
Yeah, it was just to say the advice, just to be clear, because this is public, was significant headaches over a number of days that was worsening and not getting better.
Yes, the subtleties are often lost in the
absolutely the interpretation of that.
Yeah.
Yeah, lots of people in my experience have severe headaches over the weekend. Anyway, moving on. Anything else? No. Okay. The finance part of it then, Anil.
Good morning. Thank you, Alan. Hi, everybody. Just to say, in terms of finance, there's probably 3 key points to mention. In terms of our revenue position, our IGR position here is before we get the national top-up income. Once you take that into account, we've got about a £1.9 million deficit bottom line in actual terms. And we knew that was going to happen. We understand why. That's mainly down to the fact that we have an annual leave cost built into that position, which will be nationally funded by the end of the year. taking that into account, our year-end position remains a forecast of break-even. We recognise there'll be additional funding we're still requiring around non-clinical income, annual leave and COVID-related costs, which we still expect, which should support that year-end position of break-even. As a system, we've been working very collaboratively on our financial position. And again, from a system perspective, we expect to hit a break-even position as well. That's all good on that front. In terms of capital, we're currently underspending. We are forecasting an underspend at the end of the year. There's two key elements related to that. One is we've had HIP2 seed funding this year of 3.7 million. We won't fully spend that by the end of the year, and we recognise there'll be plans to continue our development on HIP2 programmes next year. So we are rolling over some of that funding into next year, which is the underspend of about 1.5. We've been talking about no additional COVID capital funding coming through the second half of this year, but we were surprised and fortunate to receive an extra 900,000 COVID capital funding at the end of this year, last month. That wasn't planned for, hence that's another reason for the underspend at the end of the year. We touched on financial planning earlier, so obviously the planning guidance has come out. So on the back of that, we always knew that we would need to develop our plan for workforce activity and expenditure. We have been doing that in the background. What we now do is align that to the planning guidance that's now come through. And clearly what we do is triangulate all three elements around activity, workforce and finance, internally as a trust, but also with our system partners. So again, one of the requirements is about putting a system submission in May and June, and therefore we'll be working together on developing the full plan. Other than that, there are no other particular highlights from a finance perspective, unless there are any questions. Thank you.
Thank you. Lisa, anything to add on that bit?
Yeah, I think just the final thing for me to add is just for the board to note that we also held an exceptional PF&R meeting where we went back and looked at the business case for the University Hospital accreditation. And that was off the back of a callback where we'd felt that some of the benefits of that business case weren't clearly articulated. And just to note that that has now been approved by the committee as well.
Excellent, thank you. Trevor, your hand is up.
Yes, thank you. Neil, in terms of the late funding coming down for COVID for capital, is that able to be spent next year? Is that actual resource come down, or is it a case that we've got the money but we're not going to be able to spend it?
We've had the money, but we're unable to spend it this year. I think what we're looking at is what discussions we can have with the national team and region around how that could be made available, recognising the slippage we've had on capital plans that we originally planned for this year, which weren't able to take place to support some of the estates that were required for COVID. So that's a conversation we'll be having in the system with our regional team to look at what we can do around that.
Okay.
Thank you.
Thank you. Right. Yep. All done. People, Mark and Janet, you've got a lot of agenda items, Mr. Smith. So let's try and keep this one neat and tidy because of all the time we've got on the important issue of people later on.
You sound like you're speaking from experience about me talking for too long about people, Alan.
Let's just say it was a helpful comment.
Okay, thank you very much for your comment. In terms of the sickness absence, I just wanted to pick up a couple of answers around people, and particularly in relation to sickness absence. So colleagues will see that we didn't have as high a peak in wave 2 in relation to sickness absence as we did in the first wave of the battle with COVID. And we are putting in things to support colleagues. We have been putting in situations to support colleagues, both into return to work and indeed to prevent them from being unwell. We have recently partnered across the ICS, or across the future ICS in a couple of days' time, the integrated care system with NHFT, NGH and colleagues in setting up a Stronger Together hub where people can access mental health provision at a very early stage very quickly in order to provide additional support for colleagues, given that that is our #1 reason for absence currently. But we are continuing to work because we haven't seen, whilst we didn't see a peak as dramatic as we did in the first wave, the reduction equally has not been as dramatic. I know it looks like it's gone down quite considerably from January to February, which it did, but March is pretty similar to the February position and is not following a trajectory in terms of downward trend. And we hear that, as we have already heard through today, in terms of Leanne's contributions around the staff that we have available to us on a daily basis to support our patient care and delivery. So we're continuing to work on what we can put in place to support colleagues to return to work. And of course, the national shielding instruction comes to an end as of tomorrow. There is additional guidance that we have in relation to how we support colleagues returning to work that have been shielding for a considerable period of time in some instances, and we're currently working through that. In terms of vacancy, international nurse recruitment has already been discussed, and we can see our vacancy position is reducing. As I always say, it appears now on my annual conversation around this, in line with the operational and business plan that we're going to be submitting. We need to also then look at what colleagues or what workforce we need to support our services. And then in historic terms, we always see an increase in May and June. And that's why we're putting an international nurse business case together that far exceeds that. So we're working to try and reduce those vacancy rates, not just the current, but also what we plan for the future as quickly as we possibly can. It's a huge investment, and again, work that we're doing across both hospitals and indeed across our system. And that's to compensate for situations such as in year. Obviously, we've put our paediatric ED in fully established during the course of this year in a different environment. The final part I'd like to touch on is in relation to training. Whilst we talk about the specifics at this and have talked about these at the People Committee and will continue to, in terms of a full breakdown, clearly as we move out of the pandemic, as we have seen it in the last 2 waves, we need to improve our position in relation to training and education and indeed appraisals. It's really important. We do absolutely, and we've talked lots and we will continue to talk today around the support that we give to our colleagues and our staff, and having that conversation with them in whether it's with appraisals or just how our people is going to be really important, and we're going to need to monitor that moving forward. The final point that I'd make under this particular element is that our metrics as we see them at the moment may well stay the same, but equally they may change in line with the people plan that we're putting forward. And we're having a session in our joint People Committee in April with colleagues on this call and indeed from Northampton to look at those metrics and to see whether or not they align now to our ambitions in and around the people plan. Thank you very much.
Okay, any hands up on any points on there? As I say, we have got a lot on the people plan later, quite rightly, and it will be a topic for the next, well, long time, but particularly the balance between now and the end of May on the balance between staff and recovery. Nothing there at all. Thank you very much. Janet, anything you want to add to it?
I think Mark's been very completing what he said. I just want to make sure everybody's aware that we did review the indicators. We've been looking at the risks associated with key things. It's a really exciting time in terms of what's being offered, particularly around the health and wellbeing areas. One of the things that we did do at the meeting on the 22nd of March was to review a workforce issue that was raised to the committee by the chair of the Quality Committee. So just to confirm that was raised and has been addressed. Thank you.
Okay, thank you. Good. Charitable funds, there's only one topic on there, and then it's on our agenda later on. Do you want to just mention what it is, Mark, or are we happy just to move on?
I think we pick it up in our private board meeting later.
Yeah, thank you for that. Okay. Strategic Development Committee, Polly.
Yes, thanks, Chair. So delighted to confirm that we did submit our strategic outline case for the redevelopment of Kettering Hospital site. So we submitted that to NHSIE, our regional teams, right at the end of February, beginning of March. So they are currently going through due diligence and process on assessing our strategic outline case for the redevelopment in line with HIP 2, and I shall feed back formally to the board when we hear back from them. But other than that, we are looking forward now, moving forward over the next 3 and 6 months to completing a greater level of design. We shall be running some stakeholder and patient engagement events over the forthcoming couple of months to really start to engage with our staff and our patients on the detailed level of design, facilities, the way we might use the site, car parking, and so a whole range of things that we'll be looking to do over the next few months. Thank you.
Okay, thank you. I don't have anything to add to that. And we're talking about it quite a bit in the afternoon session. Okay, nothing else there. No. Digital Committee, Andy.
Thanks, Alan. So the Digital Committee, we are now veterans at having a group meeting. We had our 4th group one on in March. And the main business of the board, as the committee, sorry, has been around the digital strategy, which I'll talk about later. The other factors that we've discussed is around the electronic patient record program at Northampton, and just starting that work as we move towards a group electronic electronic record. And we also noted the award to NGH of the Robotic Process Automation Centre of Excellence. That started in December, and that's one of 2 trusts in the whole country that have been selected for that piece of work. And currently NGH, that team there, are supporting 10 other trusts around the country. But that work on robotic process automation will flow across the whole of our group.
Okay, Alice, anything on that? We are talking quite a bit about digital, and I want to talk in the later session on that about some very good conversations we had with NHSX. But Alice, anything on the committee?
No, absolutely. Echo everything Andy said. I think we are now starting to think as one team. I think the key challenge we've still got to crack, which won't happen overnight, is getting a team across the 2 that are at the stage that I think we're starting to get the Kettering team now. We need to get the Northampton team up to that so we can really work interchangeably across the 2 and get the real benefits from that. But I think at a senior team level, people are now starting to work like that, which is great. And I think the appointment of the new digital director at Kettering is a positive move. And as soon as we can get the same in place at Northampton, that can start trickling down. I think that's the key challenge for me, really.
Okay, thank you for that. And finally, Collaboration Programme Committee, Simon.
Thank you. So in addition to the report as tabled, just to draw attention to 2 things. The first is that we will be coming back round the table in April to start discussing an approach to how we consider group risks. I've had some endlessly entertaining sessions with the 2 directors of governance, defining and thinking about how do you conceptualise and then describe group risks, which have been really interesting, genuinely. And so we hope to present that work to the committee in April. And the other thing to alert people to, which I just think is really important, is clearly a huge amount of work going across both hospitals on what do we mean by transformation and how do we make sure that we have the right capability and capacity to really support the ambitions that we have described. And I'm very much looking forward to the discussion in April and then at the board development session when we will explore those topics in a great deal more detail. That's all I've got.
Alice, anything again?
Thank you. Yeah, agree again with what Simon has said. I think for us, for the NEDs on the committee, the group risk piece is absolutely key, and it's something we were concerned mustn't be forgotten, if you like, that whilst we understand that from a legal entity perspective, we manage risks in individual organisations. Obviously, the work we're doing to collaborate brings with it some group level risks to consider, and we welcome those then being brought forward in April. I think that's really welcome to the NED members of that committee. I think the other thing I would flag is that on the clinical collaboration piece, I think that's really highlighted the need for that transformation resource to be in place, and also the need for that to include some substantial OD support as well. I think that's really flagged that up from everything we've seen. So looking forward to the work that Polly and the team and the opposite team at Northampton are leading to think about how that target clinical model works, and then how we help support the teams to get there. Because I think at the moment the progress has been good, but perhaps not as fast as some people would want it in some areas. And there's a few things perhaps that we need to really think how we support the teams to drive forward.
Okay, anybody got any comments on that? I think the CPC is a particularly wide-ranging and kind of challenging committee to chair. So I'm particularly grateful to Alice and her opposite number in NGH, Rachel, because it's, they really are keeping track of quite an enormously wide range and probably growing range of issues as they think their way through, and some quite complex debates about the way forward. It's also a very forward-looking committee, as you might expect. It may become something to do with performance as well, and is looking at that in in the clinical areas, but it's very much a forward-looking committee, as in what are we going to do about transformation? What are we going to do about head and neck cancer services and so on? And that requires, you know, they are wide-ranging committees and well-attended committees, which is a sign of how much the exec and others wish to see this as an important area. So other non-execs are welcome to join that committee at any time, of course, and they will be, I think, looking at joint committees in a pre-arranged programme, Alice, as I recall correctly, as you will be looking at group priorities in a pre-arranged programme going forward. So there's a number of things beginning to lay themselves out in the direction there. But I'm very pleased with the progress of that committee from quite a rapid start. So thank you for that.
I think Richard's raised his hand to mention something on that, Alan.
So he has. Richard, thank you.
Not on the Collaboration Programme Committee, but on the IGR as a whole.
Carry on.
So those of you that remember the fantastic board training that we had with Sam Riley from the national team only 18 months ago, and thank you, Alan, for mentioning the exemplar commentary we've had from the national team, a number of metrics have experienced what we call a shift, i.e. from there to there, and it's probably time that Andy and I work with the team on recalibrating some of the process limits so that we can get a bit more sensitivity in our analysis as we come out of this second COVID wave and hopefully reach a sustainable position. So just a note really to say we'll do that piece of work, and when we come back in a couple of months, things may look slightly different.
Thank you for that, and I'm sure that will be discussed both with the team that set the limits and with the committees around what they want to be the reporting metrics. Because although we've got them down to quite a tight number of metrics, it's important that we keep looking at those and are they the right metrics, which when you take them together from a board perspective, they tell you enough about the hospital that you know it is running well or not. So thank you for that. Elective recovery, Faye and Andy. Now, you know, it's important that we try and link this programme into the priority and planning guidance as well, and how we make those two things come together. And we've talked about the priority, the planning guidance, both in Simon's bit, in Debbie's bit, and in Faye's bit. So preparing for elective recovery, I think this is Faye and Andy running this show for me. So Faye first.
Yep, thank you very much. Yes, this is a joint plan that's been put together with Andy and Joe from NGH and myself, and basically lays out 3 strands and our approach to how we are going to look at elective recovery across the group. As we've already discussed earlier, you know, the PTL or the patient tracking list has grown significantly due to COVID, and this is in line with the national picture. So the approach we're basically taking is there are 3 strands to this. The first one is in terms of validation, ensuring our PTLs are accurate, so we've got confidence with our data. The second is around exploring ways to recover our position, and the third is around the monitoring process. So in terms of validation and our patient tracking list, there's significant work that's gone on over the last few months in terms of ensuring that our PTLs are accurate. The reason we need to do this is occasionally we end up with patients on our list that have been discharged, or there's duplicates. So it's really important that we understand who is on our list in order to develop our trajectories and our plans. So in the past, we've been part of national audits, and we've always fared pretty well in those. But actually, validation is a continuous process. It's not something you do once. It's something that basically needs to happen almost on a daily basis. The next slide basically is just describing 3 different scenarios of what our waiting list could look like. I'm pleased to say that we sit in scenario 1. And I was challenged at the PFNR in terms of, you know, are we expecting to see downstream issues? Where are our pressures? We're actually dealing at KGH with our pressure points at this moment in time. And actually, what we need to be looking at is what's going to happen in the future. So certainly, you know, at this moment in time, we're dealing with our 52-week breaches, getting those back on track, and you can see what scenario 1 looks like there. Thank you, Andy. In terms of how we're going to address this issue, so I think it's fair to say that during COVID, we have already put significant things in place. So we've been partnered with our independent sector partners, the Woodlands. They've been providing capacity for us. We've also been insourcing activity, so insourcing company providing the workforce to help us run weekend sessions. As I've already mentioned, there's been lots of external clinical validation that's been occurring, and that's been part of a national programme, and also our internal processes. There's two things that we need to absolutely get back on track if we're going to recover and in a timely manner, and that's theatre productivity and outpatient optimisation. That's something that we were really focused on before COVID, and we need to definitely galvanise those projects and transformation. There's also quite a bit of work going on with our digital team, and they're looking to how we can introduce patient-initiated follow-ups. And as I said earlier on, all of this again is reliant on us being able to have our workforce back in theatres to be able to fully maximise the workforce that we have in order to recover. We also need to work across the group in terms of whether there's things that we can do to help each other out. But also I think there's more work we need to do with our independent sector colleagues in terms of more activity and support from those. So the next slide basically describes all the things that we've got in place in terms of monitoring, and Andy's team have already developed the elective weekly report, which, as I've already said, demonstrates that actually we're already dealing with our curve. However, I think it's really important to note, and what this report has demonstrated is that our referrals are going up, and certainly within, I think it was in 1 week, our new referrals basically increased by around 440 patients for patients sitting between 0 and 9 weeks. So we know that activity is starting to return to normal levels. So that's something that we really need to keep an eye on. There are internal and external forums and committees that are happening on a regular basis. And as an organisation, we have a reset meeting every week, and we will be repurposing that meeting in line with the recent operational guidance and in terms of this recovery plan. So in summary, validation will be and is being completed today. From an organisational perspective, there's lots of work going on with that, and our PTLs are in fairly good shape. And as I say, we've already got some independent sector and other things in place. And from next week, we will start to monitor very, very closely in terms of our recovery trajectory. Andy, I don't know if there's anything else you wanted to add.
Thanks, Faye. Yeah, the only thing I'd add really is this is a real data driven response that we need to have here. So as Faye said, the report that's being produced on a weekly basis will develop over time. You know, it's clear already the first iteration, there's been some suggestions to make some improvement to make it operationally useful as we start to drill into it. But really, this is a case of using our data to derive our activity.
Okay, any comments at all on that and on the work that's in hand there? No, I'm not. Trevor.
Thank you for that. Where are we with regard to imaging? Because I'm recognising that some of the capacity issues, you know, theatres we're talking about here, but are there other issues around things like imaging? That's the first part. And the second part was when we looked at wasn't just reset, but just trying to deal with waiting lists in the past. There's clearly some specialties that are harder to tackle than others. So in terms of the numbers, I'm presuming that granularity will be in those numbers, but are there resource issues that we need to be looking at up front in terms of how we support those difficult areas?
So let's just hold that and gather a couple of other points, Faye and Andy. So Lisa Llewellyn, please.
Yeah, mine is really about, I think this is a really good example of digitally driven, hospital-focused recovery on elective waiting lists. Follow the numbers, and it's really impressive that it's joined up. My question was, and I'm going to answer the first bit myself, I am assuming that we are going for the, I get the name wrong, the Elective Recovery Fund, the extra funds that are available. So I wonder if somebody could kind of describe how we're tackling the other aspects that are within that, which are absolutely about tackling long waits, but also require us to demonstrate system-led elective working. In Andy's sphere, and Deborah mentioned it early, digital transformation, so we're doing digital outpatients. But you won't be surprised that the thing I'm going to come back to is health inequalities in all of this. So really challenging us to look at how people access our services differently.
Okay, thank you for that. I'm not surprised to hear you talk about it. Alice.
Thank you. It's sort of leading on a little bit from what Lisa said there around if somebody could helpfully sort of explain the link here between how we're going to be funded and the plan we've got here to bring those waiting lists down. Obviously, we all want to bring those waiting lists down as soon as we can, but it'd be helpful to understand how that becomes affordable, particularly as our relationship with the independent sector changes and so on.
Thank you. Yeah, Andy.
Thanks, Alan. I was just going to respond to Trevor's point around the granularity. I can confirm that underneath the broad PTL results, we're going to be breaking that down by speciality level. So that will allow us to understand which parts of the PTL profile and which speciality are of concern at a given time.
Okay, and Anil, I think, next.
Thank you. Just a really quick response to the funding aspect. So essentially, I think there's further work to be done on that in terms of how we do access that and how that works. I think it's very much like an incentive recovery fund in terms of there's a set level of, there's a set target of expectation in terms of the activity you'll deliver within the block envelope that we have for H1 or the first 6 months. And then subsequent to that is then how we do additional work, and the cost of that additional work, then we can claim funding from the ERF. It's a principal logic, but I think there'll be more that comes out on that in the future.
Yes, I agree with that, but I think the key is how are we going to see this report against that target so that people can understand exactly what the progress is. Simon.
Thanks, and I know colleagues will wish to comment because there are lots of people around the table who've contributed to this work. And so the first thing I wanted to say was thank you. I think I mentioned in my comments up front, business intelligence is going to be at a premium this year. Our ability to analyse what's going on and to know it, real important skills, and we made a really good start on that. Just on some of the points that have been made. Health inequalities, which I think is going to be a really important lens through which we look through elective recovery this year. So the first part of that is an actual looking at our PTL, because even within the waiting list, health inequalities can grow. So some people get access to treatment more quickly. Some people get access to for all sorts of reasons, and we need to make sure that we understand our waiting list, not just by the traditional time series, but also making sure that we've really understood clinical need, access by different types of community, access by age band, access by gender. So we are going to be delving far more into our PTL than we would have traditionally done to really make sure we're understanding the health inequalities point that you raise. The second place that health inequalities comes in is probably the $64 million question. Is we've got two challenges to deal with. We've got backlog, so people who have already passed 18 weeks, and we've got bounce back. So bounce back is going to be a new vogue term. I'm sure, Lisa, you're already aware of this, but we all know that demand has been suppressed in the NHS over the last year. And a lot of people with much bigger brains than I are trying to work out to what extent is that demand going to come back into the system in the year ahead. And that is a really big question for us to grapple with. And why this report is so important, and future versions of it are so important, is we've got to track the PTL at two ends of the spectrum. One is at the far right-hand end of the curve, dealing with the people who've waited for a long time or who are clinically urgent. And the other is to understand patterns of activity that are coming back onto our waiting list as we go into the year ahead. That all is very complicated and difficult stuff to do. And we need to get our heads around it as best we can prior to submitting the May return. So Alan and I has asked me, working with colleagues in Northampton, because this is such a big subject, to arrange probably in the second part of April, when we've done a bit more thinking on this, a board seminar for NEDs to take them firstly through the planning guidance, but also through some of the detail that sits behind the numbers, so that we can test ourselves on those lenses that you and others have raised. Are we really doing the best we can? Because even then, within that, another lens through which to look at health inequalities, just to conclude my thoughts on this, is that it will vary by specialty, because obviously we don't have the same access that across all of our specialties. So hopefully, because we can't do it justice in a condensed time that we've got available here, but hopefully a board seminar to give everybody a chance to bring together what we're trying to do operationally, how that works with the money to pick up those questions. Anil's right. Essentially, activity above a floor will attract incentive payments. And I was talking to our new CFO, John Evans, yesterday about the fact that at some point, and here's his phrase, first drop in from him, we're going to have to back ourselves to invest in some capacity to pull back the waiting list problems that we've got, because simply doing more of what we have done or what we would have done pre-COVID isn't going to cut it. I know that was quite a long answer, but I know I was trying to pick up the complexity of some of the issues that people have raised. Locally, I should also perhaps invite Polly to comment, because she is chairing our elective recovery group at a system level. But that was it from me.
Polly, I handed up anyway, on you go.
Absolutely, yeah, I was going to, so I agree with everything that Simon said, and I was going to come in on answering that point. So Simon said we do have a system elective care board that was set up in response to managing the risks around elective care during the pandemic, but we are now relaunching that board. I'm the chair of it, as Simon said. We're relaunching it really to look at all the things we've just talked about and how we manage elective care over the next year. What are the things that we're prioritising? Because there are a series of national must-dos, but absolutely bearing in mind the need to support staff across the health sector, so through primary and secondary care, and making sure that those staff do get the rest and the recovery that they need, whilst we're also, of course, driving our improvements in elective care and treating the patients who have unfortunately been unable to access treatment over the last year. So the board does include a very good representation from primary care colleagues and GPs, from the acute sector, clinical leads from the acute sector and the independent sector. So we're all working together on that. Key things really are making sure that we have or can deliver equality of access in terms of waiting times across providers. So we'll be looking, I think it's referenced in the slides that Faye just presented, a system PTL, a system view of the waiting list.
so that we can absolutely make sure that regardless of where you're treated in the county, you're getting equality of access and waiting times. And that's not something that any system really has been able to do before. So we'll be doing that through the system PTL. We're also looking in that group at the health inequalities across the county and at specialty level, as Simon referenced. And also, I've not heard the term bounce back that Simon referred to, but those patients that haven't been coming forward to their GPs, to their primary care, and we know that there are, we don't know the volume, but we know there is a volume of those patients. So one of the things we've been talking about at the System Clinical Leads Group is actually how we jointly manage the risk, the clinical risk of those patients. So traditionally, for example, the GPs would refer a patient into secondary care and almost transfer the clinical risk onto secondary care. And one of the things that primary care colleagues, as well as secondary care, are very keen to do through that group is actually work together on managing the risk of those patients, because we all totally recognise the fact that just referring patients into secondary care isn't going to adequately be able to manage the risk or treat those patients in a timely manner. So it's how we're looking to do that. So those are the key things that we're going to be doing over the next month or two. But I just want to give some reassurance on that from a system perspective.
Okay, thank you for that. I don't see any other hands up. Just to say, the seminar is kind of an example of what I said at the beginning about working over the next couple of months towards the May meeting to reaching a conclusion about the balance between recovery and of patients and of staff. So I think that will be a very interesting and slightly testing board seminar, if you like, because the issues are complex and interwoven, and it's those kind of big brain problems that boards are meant to solve. So we've got a list of things that from some of you today, but if there's anything you particularly want us to, or want to make sure that we address, open up, debate, talk about in the seminar, please let somebody know. I mean, I think you can work out who it is from what the topic is, but certainly, please let us know what that is about. And the other thing just to say on that is, I see Peters, as usual, is here as our lead governor. I've asked for a seminar for governors on the planning guidance so that we can talk to and with, listen to our governor's concerns, particularly around understanding the consequences of the duty of collaboration, which is laid out both in the Act and in the planning guidance. Versus the desire, not surprisingly, of our governors to focus on issues at Kettering Hospital, because that's where the governor's for. So I think that changing balance of instruction, of requirement of us about how we think about it, and as I'm sure we will think about group PTLs and group opportunities to address that, we need to have a good understanding of how our governors think about the issue of collaboration versus their own particular role. So those two things will be happening. I don't think I have anything else. Just let me check the last check. I see Richards is saying we have some network problems. So yeah, yes, I see that. So some people in Glebe House seem to have network problems, and we'll give you a few minutes to sort it out. So in all that, you've arrived 5 minutes early at the break point, so you now have a 10-minute break. Please be back at 11:40. Thank you very much, everybody.
Oh,
There we go, 11:40. We should all be back as cameras all start to come on. Excellent. Click, where. Okay. Yes. Okay. We're there. Thank you very much, everybody. Board assurance framework, risk registers, BAFs, COVIDs, and such like things, as well as the patient group priority and the group priorities. So it's an increasingly complicated board assurance framework. Richard.
Thank you, Alan. So 3 things to just highlight to the board, taking the paper as read. Following the January board approval of the group priorities, the board assurance framework has been reorientated from KGH's strategic objectives as were to the new group priorities, and that's a piece of work, as you alluded to earlier on, Simon and Alice, that we'll be taking through the Collaboration Programme Committee in common with Northampton. And this is the first step on that. And just to say that this will be an iterative process as the board assurance frameworks between the 2 trusts become more aligned around those shared objectives and priorities. As part of that work, there is a new risk on the board assurance framework around patient experience, and that fits under the patient strategic, group priority as a new risk for Kettering. And then thirdly, the COVID high-level risk register, which we've had in place for almost a year now, there's a risk on there that has been reviewed with a greater focus on the health and well-being of our staff and the chronic as well as the acute effect on our staff of our response to the pandemic, and all of the support that Mark has already outlined and will outline more through the people plan conversations that we are putting in place. And as part of that, the risk score for that risk has increased. And I'm happy to take questions.
Okay, anything at all on the BAF stroke risk register? Somebody's on. Trevor.
Sorry, apologies, problems unmuted. The board assurance framework and the change, are we taking this to the audit committee, the next audit committee? Just that I'm concerned that we've got it's not a major change of focus, but we have got a change of focus here, and we need to be aligning our plans for future audits and things like that around this to make sure that we are getting the right assurance in the right place going forward.
Yeah, that's absolutely right, Trevor. We'll be bringing it to the next audit committee and making sure we've been speaking, as you know, to our head of internal audit from TIA to make sure that next year's audit plan is well aligned to the board assurance framework.
Okay, thank you, everybody. Yes, that's that. So staff survey results and then the group people plan. It's our favourite chief people officer's show now, and they do tend. I'm just looking. I've slightly lost Mark on my. Oh, there he is.
Don't worry, he's here.
Yeah, no, I was just a moment of panic, Mark. But you're fine. So I mean, you're in charge of this. You've got quite a long period of time. You've got the 2 topics. Please blend them as you see fit, and get us to make sure we cover the ground that you want us to cover during the course of the time slot you've got, which takes us, I think, all the way to about 12:30. So you've got quite a bit of time for this one, Mark. Quite rightly so. Over to you.
Thank you very much, Alan. So, and thank you. I'd just like to take us through the staff survey results, a couple of which colleagues have mentioned during the course of the meeting already today. So I don't wish to labour some of these points, and just at the outset, I should probably say both the staff survey and its full entirety is available on our board packs, and both the KGH and NGH full staff survey results went to the Joint People Committee in on the 22nd of March. So the 450 odd pages so colleagues could look through each of those. And obviously the people plan has also been through and approved at that joint people committee too. So if I can take us through our staff survey results first for KGH, and then I'll move into the people plan. So as Debbie rightly said, we had our best ever response rate. I remember sadly reporting a response rate of under 40% a few years back in terms of our staff survey participation. And now to say that we have increased that, not just increased that this year, but and this particular year, given all of the circumstances that we've all been facing, to move up another 7% has been a huge achievement. And just is testament to how colleagues are engaging with us within the organisation, and hopefully is testament to also having seen changes from when concerns had been raised previously. I know my own personal example of that, whilst a year or two ago in working in the catering department and seeing the conditions in which colleagues were working within, we were able to make changes based on the fact that they'd raised concerns via this survey. And that's a really important thing that we have to keep remembering. We have to, in order to maintain a response rate such as this, we have to keep acting upon the feedback that we receive. I would also just put that into a wider national and indeed regional context, that many other organisations actually saw a deterioration in this year, again, probably given the concerns and situations that we had in managing the pandemic, but we saw an increase, and I think that's fantastic. From an overall results perspective, there are themes, as we've talked about here on many occasions. There are 10 themes, 5 of which improved for KGH in the last year from 2019 to 2020. There was a reduction in 3 and 2 remained static. And if I am honest, in terms of an overall an overview assessment of the entirety of the staff survey results, then my assessment would very much be using the phrase status quo. We've maintained a position that we had in 2019 into 2020. We've had some ups, we've had some downs, which we'll go through in a second. But overall, it feels to me this is a really exciting time and opportunity for us to launch our people plan after today, after we have approved it, and to take the next step. In our group priorities, as we set out in January, and indeed as is set out in the people plan, we have a desire to be in the top 20%. So being average and being in the middle is not good enough for us and for our colleagues. And we want to improve our position into that top 20%, as I've discussed. In terms of the theme related questions, as you can see here, in terms of this status quo, we had 29 that improved and 31 that deteriorated. And I'll go through some of the highest and lowest of those improvements and deteriorations in a second. But a majority of both our themes and our questions sit in and or on around the national average for acute providers within the NHS. And you can see that in the full detailed breakdown of all of staff survey results that are also available publicly. And in terms of then how we've communicated these results within the organisation, so we attached the full results for all board colleagues and again people committee members via the staff briefing, so group briefing, which we will do, and the 2 organisational briefings in both NGH and KGH. For KGH specifically, Paul has been able to articulate where our staff survey results have fallen and where we are at the moment. And indeed they're on our intranet. I also sent an email out on the day the survey was produced on the 11th of March, when it was cascaded across, because we had known our position from 2019 to 2020, but it gives us the fully benchmark results from the 11th of March for us to see where others have improved in other areas of the health service, that we can then ask them comments and try to make improvements ourselves, similar to that colleagues are doing for us in relation to our integrated governance report. If I could take the next slide, please, Kieran. Thank you. So as we can see here in terms of our themes at a glance, this is the overall 5 up, 3 down, 2 remain the same slide, and therefore also where we are compared to the national average. And you can see what I'm saying here in relation to in or around or on the national average in a number of areas. So while we have seen improvements in relation to bullying and harassment and creating a safe environment for colleagues, that is not at level with national average, and therefore there is still more work to do. We don't just get blinded by green here and say, okay, that's all good. Let's move on to the reds and only focus on the reds. We look into those in more detail. If I could take the next slide, please, Kieran. So in terms of our largest changes, or the most significant, statistically significant changes, in terms of some of the questions that we have had. So we, according to the responses that we have received, we do not have colleagues that have turned up to work feeling that they're not able to perform their duties, or we still have some given the percentage, but less than we had previously in terms of that 12.6% improvement, which is a significant improvement. colleagues are no longer considering leaving their job, or less likely to consider leaving their job, which is also an improvement. And we see that in our turnover statistics. I hope colleagues would recall in the last 2 years, our turnover position has continued to reduce and is indeed below targets. But I acknowledge that those targets may be re-reviewed over the next couple of months in terms of a further stretch and for those. In terms of staff in the organisation, in order for colleagues to be able to do their job properly, that has increased, but when you look over at the percentage, it's still not enough in terms of people saying they're able to do their job properly based on the number of colleagues they have around them. It's 37% now, obviously from 32% previously, but that still means that there's a good 60% of people that do not believe we have enough staff to carry out the duties in which we are undertaking. And Debbie mentioned this right at the opening, which is one of those statistics that is really important in terms of staff engagement, which is why we want to be in the top 20%. We look at motivation, contribution, and recommendation. And within the recommendation element is those two acid test questions, if you like, in terms of if you or a friend or relative required care in this organisation, would you recommend it? And equally, would you recommend the organisation as a place for people to work? And you can see there's been a statistically significant increase in this particular answer to this question. I have mentioned in terms of motivation and contribution. In terms of motivation, there are issues clearly there are issues in terms of levels of pay. We are predominantly bound by the national position in regards to pay, and that's been well documented a couple of weeks back, and we will see as to what happens in the future from the pay review body work which has been undertaken. And I would just remind colleagues, obviously the pay review team visit a number of organisations and speak to a number of people across the NHS before they make their recommendations, and we were in a privileged position this year in KGH in order to contribute to that. We were asked by NHS providers to be an organisation that contributed, and we absolutely did. In terms of colleagues being able to decide changes, this is the contribution element of that staff engagement factor: motivation, contribution, recommendation. The contribution, how is it that we ensure that people are able to make suggestions, but not only make the suggestions, but also implement them? And how do we ensure that they are communicated with and consulted with in terms of changes that are to be made? And clearly we've got further work to do on this, and we bring that out in the plan. And teamwork is clearly another area of concern for us in terms of when we continue to roll out our new values in the very near future, we really need to continue to emphasize on this element of respect and how we treat one another with respect and how we work as a team. We team and reteam within our NHS organisation on a number of occasions, on a number of bases, on any one day. And today alone, I will be part of 3 different teams in terms of 3 different meetings that I will be attending. And that is something that happens for all sorts of colleagues, and we've talked on Facebook earlier about how we're reintegrating our theatre colleagues and teams back into that environment, having previously worked in ICU, and we do need to put more intervention into that particular area. If I could take the next slide, please. So in terms of our comparison to national average, so this is, as I say, I called this question out, and this is something where we need to work on. So we have seen improvements, but we are still 5% or 4.9% away from at least the national average. And of course, as I've said, we want to get even better than that. If a friend or relative needed treatment, I would be happy with the standard of care provided by this organisation. So whilst we have seen improvements since 2017, we absolutely need to work harder on this. We need to talk to colleagues about what that looks like and why colleagues don't feel that is the case at the moment, and what would we need to change in order for that to happen. I've mentioned just previously in relation to teamwork, in relation to respect. How do we ensure that colleagues do receive respect on a daily basis in terms of their interactions with others? That's everybody's responsibility and everybody's duty bound to do that. And then we need to also, as part of that teaming element, look at the immediate line manager and encouragement in the workplace, because that is something clearly we have work to do upon. There are areas where we have questions that are better than the national average, and you can see them here, and I've mentioned a couple of them already in terms of colleagues not wishing to leave the organisation or not thinking about leaving the organisation. Strained relationships, and this is where with this staff survey you have to triangulate quite a lot of the data, because the relationships, it would suggest, this score would suggest that relationships are less strained. but the teamwork element is still an issue for us, as is the respect element and indeed immediate line manager. So what is it that's missing? What is it that we could do better in this particular area? And colleagues be feeling able to deliver the care they aspire to. So the question in relation to recommendation of the organisation, colleagues believe that they are providing the best possible care that they can in terms of the circumstances they're working in. So is it what they see in other areas is what affects their position on that particular question? And again, we need to ask people that, because that's how we obtain the answer and then can take action duly. Next slide, please. So these are, as I've pretty much covered these, in terms of statistically significant changes, and there has been an increase in relation to health and well-being, and thankfully so. I would like to take this opportunity. We have put a number of initiatives in place over the course of the year, and I'll talk through how we're going to continue that in the people plan very shortly. But even just today is a monumentous day for us as an organisation, where we have been providing free meals to colleagues of an evening every single evening since the winter. And today is the last day of that, where we will be not continuing with that service as it stands at the moment. And colleagues have been so colleagues have found that beneficial, but equally they understand that we're moving back into a different working environment, and we are utilising that group led by Jane, who's one of our staff governors, to look at what we can do differently, because what people have enjoyed about that, and they're not so fussed necessarily about the cost of the meal, it's more around the flexibility as to when they pick it up, how they can order it. So there is something for us to talk to people, and we've had the best possible feedback in terms of people have enjoyed it, but it's also a good opportunity for us to ask people feedback about what they'd like in the future. I've talked already about a number of other initiatives that we've put in place, including the Stronger Together Hub with our colleagues in NHFT and NGH, whereby colleagues can obtain access much quicker to mental health provisions, which is absolutely fantastic. In terms of a safety culture, our staff survey results tell us that we have our organisational responses to issues is much better, and people will and they do feel able to raise concerns and indeed have these addressed. And I think, you know, we see here as a board on a 6 monthly basis, Susan comes to talk to us in relation to her Freedom to Speak Up reports, and that stands true. Team working, as I have said, is an area of improvement that we need to work upon. How do we encourage better teamwork than the results we are currently seeing within our staff survey? We have some excellent teamwork which is demonstrated in and around the organisation. Leanne mentioned earlier the work that the colleagues in Harrod and C and the paediatric teams, of the way they've had to work with one another in order to facilitate those moves and those changes has been fantastic. But clearly we have work to do within the organisation to make sure that that is the case all of the time, not just in some areas and some of the time. My intention, Alan, was to pause there just to see if we had any questions in regards to the staff survey. I would just preface that by virtue of saying that the results that we have taken here, the obvious next step for us as a board to consider is what to do about them, and that is coming in the next agenda item in terms of the people plan. So I'll just pause for a second in terms of any questions.
Okay, thank you for that, Mark. Good and not so goods in it, but it's important we understand what's going well and what is not perhaps going quite so well. So, Lisa, and then Alice, please.
Mark, I was interested in I think it was an increase in the number of people that felt that they wouldn't come to work if they didn't feel well enough, which is really positive. So people staying at home. Do you think that was because of the guidelines around COVID? Or what do you think might have contributed? And how do we keep that? Because we shouldn't be encouraging people to come when they're potentially infectious, but also it's not good for them, more importantly.
Yeah, and undoubtedly, I believe that the COVID in totality had an impact, and I believe the impact that it had, which is absolutely a lesson we need to learn taking forward, is the flexibility. So it wasn't always for all colleagues so rigid about you must attend work and it must be here. Now, we are a people service and we need people to treat and look after and care for people, but we equally can and were more flexible in the last year, and we need to look to seek to continue that. Sorry, you keep moving around on my screen, so I have to keep chasing you as to where you are, but that's because hands up are going in different places. But so there is something in for me, and we have learnt, and we need to maintain that position. Absolutely. I think it has been because we have been more flexible, more accommodating than perhaps historically we had been, whether it be childcare, whether it be people feeling unwell. You know, we've been able to accommodate people to work in a slightly different way.
Thanks.
Alice.
Thank you. It's just to pick up on the point really that you hinted at there, Mark, around immediate managers. And it's quite striking when you look at the detailed report that almost every question that mentions the word manager, we're not where we want to be, but also there's been a slight decline. Now, whether that's statistically significant is another question, but clearly something not quite right there. Just wondered if you got any insight about what groups that was in, whether that was in, you know, clinical, non-clinical, or clinical managers, but managers in clinical areas, or which of those three, or all of.
I think this. Thank you, Alice. I think the survey results would tell us, or tell me, or all of. So I am not trying to. We can obviously break them down into directorate, into staff group, and so on and so forth. But for me, I think we have to take that as a total of all of, given the frequency of that being an issue. I think my honest appraisal to this is, and this is why in the people plan we've looked at people partnering as an issue. I think there is something around our policies and our processes that we need to support our managers to be more confident in. I feel sometimes that we not protect ourselves with the policies because we should apply them, but I think we sometimes can perhaps be too rigid to the policy says this and therefore this must be the case, as opposed to let's have a conversation and see why this situation may have arisen, or how can we be more supportive in that request, whatever that request may be for colleagues. So I think there is something around providing colleagues with the confidence that they can have those types of conversations, and it's not going to be everyone's throwing a book at them to say you didn't follow policy. I think we need to make our policies more enabling for those types of conversations to happen, as I say, rather than having to follow the letter of the law as it may be prescribed. And of course that is important, that's why we have them for consistency purposes, but there is so much to be had in relation to a conversation. And one of the changes, in fact, even from the people committee on the 22nd of March in the plan, because it's forever being amended, is something around the human factors element and the human factors education that we're going to look to institute across the plan and therefore across the group.
Thank you.
Trevor and then Andy.
It's really, Mark, a sort of triangulation on that last point with freedom to speak up. And it was touched upon in a meeting earlier on before this, which was how we make the different routes more comfortable for people, whether it is that one-to-one conversation, whether it's a group conversation, that actually, and freedom to speak up is one of those conversations that's just an acceptable part of generally how the organisation runs. And so I suppose my concern is that we get a duplication. We go down one route on freedom to speak up and another route down the OD strategy, and how we link them up just to make sure that we actually are heading in the same direction.
Yeah, thank you, Trevor. And it was another key piece of feedback in the creation of the people plan, was how to incorporate freedom to speak up within that, to make sure that they weren't two different tracks running at the same time, and the amendments that we therefore made to people partnering. I honestly think the comments that were made earlier today in terms of the quality summit that we had and the never event situation is something that we absolutely need to amplify and cascade in and around the organisation, not by virtue of the fact that we had them, but by virtue of the fact that we had them, we acknowledged them, we learned from them, and we're all working together on that, and we've made changes to it. I think that is the culture that we need to continue to foster and grow in the organisation, so people feel comfortable in raising anything in any forum, because they can see and they will see that action will be taken, but not feeling that they're unable to bring them forward because they'll suffer any detriment, if that makes sense.
Sorry, can I just come back on that, Mark? So some of the things that we've heard from the BAME network is that the level of assurance that staff feel about being able to bring things forward does vary. And I suppose it's how we make sure we nuance our approach so that staff are aware of it. So it's not just a case of giving out the message, but how we take the message out and how people feel comfortable with that, whether that be managers or the other staff around the managers.
Yeah, thank you, Trevor. And some of that's on us, and some of that in terms of the power of our ability to influence that is in the reverse mentoring program that we've implemented across the hospital, and then we were indeed doing in Northampton. My reverse mentor has shared with me comments and situations that she perhaps wouldn't have shared with in other forums, but we can take them forward, we can talk about how to deal with them, she can see that progressing, and then she cascades that message. Because what I find from colleagues, and Andy's better as the network sponsor to perhaps talk to this, is what I find is what colleagues don't want is somebody who looks like me turning up to the BAME network to say this is what you need to do. What they want to hear is from their colleagues and their peers as to this is the approach, this is what I have done, and this is the response that I received, and therefore take confidence from that. So there's a multitude of ways, but the network is, well, we all see it's growing from strength to strength. And I suppose if I was then reflecting back on the survey results, in a network that's growing so successfully, and in the progression that we're undertaking in terms of equality, diversity and inclusion in totality, not just with the BAME protected characteristic, but all of them, that was in terms of the staff survey. You think, oh, how is that? Why has that gone backwards and not forwards? But sometimes perhaps you have to take a step back before you can take one forwards.
Okay, thank you. Andy, and then final comments from Simon before we move on to the plan looking forward.
Thanks, Alan. Just briefly, just to sort of pick up on what Mark said around the flexible working and distributed working, as I like to call it. I think there's some positives that come out in quite a number of factors around staff wellbeing and the ability to be able to work from home when appropriate, that yes, we mustn't lose. And I think the second thing, despite a government report that says around the situation regarding race and equality is no longer an issue, I think the numbers here tell us that our efforts towards inclusion and diversity still need to be maintained. It's a really important factor that we need to address.
Thanks, Simon.
Firstly, thanks to Mark and the team for getting this ready for our review today. Lots to feel good about, lots to challenge us. I suppose a couple of points. The first is, I think it was somebody made the comment about, is this everywhere, or is it just, is it a kind of locally specific issue? And I do think a challenge as we start to think about the people plan is for us going to be to understand who does feel disconnected from what we're trying to do in the organisation at a far greater level of granularity. There is a huge amount of detail behind all of the headline information that Mark's presented here. And I think we would do well to reflect on who in the organisation is saying, you haven't yet touched me in a meaningful way, and what can we do to address that? We've made huge progress, obviously, and you know, people have reflected rightly on the support that we put in place over COVID and the huge value that the staff have taken from that. I think we've now got to, as we come into a post-COVID world, got to find a way of connecting with everybody in the organisation in a meaningful way. And I'm not going to steal Mark's thunder because he's going to talk about that in a minute in the people plan. But I do think there's something about we need as a board to think more locally. And as we emerge from COVID and are able to start to come in visiting the hospital again, hopefully from June, I think those are the sort of conversations that will really matter to people, that we go and find them and we say to them, what's bothering you? Equally, I just want to flip that on its head for a second and say one of the things I've really benefited from working with Rabia on is her focus on the positive, and she put in the chat, but I think it's worth sharing here. I've been privileged to get along to a couple of them, but the Yockerton sessions have been hugely well received by the staff because it's actually celebrating what's working. And I don't want to steal your thunder, Rabia, because you are far better at me than explaining this, but you know, the celebration of the positive is actually sometimes just what people need, and coming together, you know, some of the things I've been privileged to hear in those sessions shows there is a huge amount of stuff going on out there that people feel really delighted about. And we need to certainly fix the things where we can, but the point I wanted to make here is sometimes in the NHS we focus on deficit, but there's also a real necessity to focus on what is working well and celebrate that and promote that. And I would encourage you all, if you can, to get along to the next one of the virtual Yockerton sessions. They are a real celebration of the triumph of the human spirit.
Okay, thank you. I don't see anybody else. Thank you, Mark. That's a good resume of the problem and the opportunity. So now, give me a good resume of the plan.
Okay, I will do so, and I'm just mindful I've got 21 minutes to do it in, which took far longer last week in Northampton than that. So I will do my best, and I am well known, if nothing else, for being able to speak quickly. So the people plan, where to start with this? It's been a labour of love for a period of time. We shared obviously the people plan version that we had in January with colleagues in the private board and subsequently with various committees, and I asked for feedback, and my goodness, did I get some. So it's we always ask for feedback in relation to these plans, and that's really important. We've obviously also included the results of the group staff survey. So across the group in NGH and KGH, the staff survey we just discussed, we had over 5,000 colleagues participation in that survey. So that is a huge amount of information that has provided us to say, what is it we're doing well and what is it we could do even better? And that's clearly been factored into the people plan, hopefully, that you see today. We also, as we've been through before, discussed this via a number of workshops in the summer. Really trying to understand where we are now and where we could do even better and indeed enhance the things that we are currently working on across both hospitals. So that took us up to January. Then I asked for feedback, and I received a significant amount of feedback in terms of the plan as it stood and what we could do differently in the plan, and emphasize some of those points. And there were points such as, well, one of the big points to that is we had people pledges beforehand. We now have 7 as opposed to 6. And one of those was exactly picking up the point that we've just discussed earlier on the item of the staff survey, is people partnering. How do we make this plan real within both organisations? How do we take it forward in both organisations? And we do that through our people partners. We do that through interacting and engaging with our divisional colleagues and therefore colleagues that work within divisions. And also, we need to be able to give people a voice to raise their concerns or express their concerns, but equally for us to demonstrate learning from those concerns that people have brought forward to us, and try to practice in a different way, as I said earlier, not in terms of so policy driven. Policy is important. Please don't let me think that I'm saying policy is not important as the chief people officer, but it's a practical approach to conversations with one another that we need to have. Some other feedback that we received that was quite significant was, yes, the plan is 16 pages long, but some people may not have the time to read 16 pages. So what is it? And can I have a sheet that just tells me, what is this plan about? What is it you're aiming to do? And what's going to practically happen? And that's the people plan on a page element in terms of action that we will take and we are going to take or have taken to support colleagues. One of those you will know in terms of the first pledges or action that we will undertake supports that of car parking. So one of the things that we are clear about, and I thank Ian and Anil particularly and colleagues in NGH in terms of what we're able to bring forward here today, is that we're going to continue with free staff car parking for the entirety of 21-22. So for the entirety of this next financial year, we are going to bring that forward. We have budgeted for it, all of that sort of good stuff. We have administered how we're going to bring that on. But that's something that staff have really benefited from in terms of just understanding, well, just having an appreciation for them in terms of coming into work and being able to park and indeed do that for free. We saw that during the pandemic and over this last year, and we've taken a decision to enact that for the rest of 21-22 as well, and that's really important. However, what's also really important, as you see here, and really relating to Polly's point in terms of the strategic development plan, we need to look at travel plans and how we encourage people to come to work, because what car parking could fly in the face of is health and well-being in terms of how we're encouraging people to attain to work in other ways. So we need to look into that. But this page particularly was our plan on a page. If nobody picked up anything else, there is 2 pages, in fact, that they could pick up. One is this is the actual technical action that we would take. And the other one is the sort of blockbusters boxes in terms of the people pledge, what this plan says and what we will do. But it was important that we related the plan back to our strategic document that we signed off in January, and indeed our excellence values that we will be rolling out there. So such a fundamental part of enacting a people plan is to ensure that the values are well cascaded in and around both organisations, and of course, indeed, in this case, Kettering. And that's a big thing for us. I talked at the private board in January, and I'm talking again now here. This is a big issue for us. Everywhere we go, the care values in KGH are really well embedded and are really impactful. And we need to change those on the basis that we're moving forward in the group model and indeed with the excellence values. And that will be something that we have to work through over that next year period. The introduction of Teresa as the group comms director is going to help significantly with that, as it will with this plan. So that's really important for us, is to be cognizant of those changes that we're going to make, but also it had to be a fundamental part of this particular plan. We looked a little bit as to where we are. We took the context into account. We have the national people plan in terms of the July 2020 people plan. I have been engaged and I'm working with colleagues for what the next version of that will look like, as Simon's already alluded to, in terms of the restoration of our people. What will the next version of the national people plan look like? And has that been, or it has, I can assure you, but making sure that it has been incorporated into this people plan, because what I don't want to be doing is sitting here in September and saying, oh, sorry about that in March, we've actually changed tactic a little bit, and this is the new plan based on the national direction that we've been given. So that has been taken into account and considered, along with all the feedback from colleagues that we have had. I could, quite honestly, as Alan knows, literally talk about this for hours in terms of every single theme and every single aspect of work that we wish to undertake. It has been an iterative process in pulling this together. It has changed ever so slightly since it was approved at the Joint People Committee on the 22nd of March. But I think, and I hope, that time would be perhaps better spent in terms of asking for any questions, comments or opinions on the plan as it stands at the minute today for approval.
Okay, thank you, Mark. That was exactly what I asked for, so thank you for that. Comments, questions on the plan going forward? Where have I got? Trevor and then Debbie, please.
Mark, on a sort of theme that we've had popping up today, which was not an HR theme, but it's about actually, do we need an IGR for the people plan? But actually we have a very clear set of metrics that everybody in the organisation, whether in management or the staff, can see actually this is what they said they're going to do by when, and this is they're achieving it or we're not achieving it, therefore we need to swap resources. Because I'm concerned there's a lot here. Maybe we've got people plan on the page, but actually how do we make sure that actually we're delivering this in a timely manner?
Thank you, Trevor. I think that's key in terms of our April Joint People Committee session, in terms of what is it we want to measure, when and how frequently. One of the things that I didn't mention in my presentation, I apologise for it, is in relation to the staff survey. We have made quite a big deal of the staff survey results issue and incorporating those into the plan, but we can't wait a year to get the next results. We have to do something a bit more on a pulse basis. How can we take stock as to where we are, and are things that we are putting in place working or not? The frequency of that, we're currently in discussion with colleagues around whether that would be quarterly or whether that would be indeed monthly, but in different areas in and around both organisations. But yeah, I'm happy, absolutely, of course, I'm happy to look at the metrics that we bring forward. There will be some that pertain to the board on a board cycle every 2 months, but then there will be some that we need to look at and own and take forward as part of the Joint People Committee.
Okay, let's gather 2 or 3 thoughts this time, Mark. Debbie, then Lisa, then Alice.
Yeah, thanks, Chair. So tomorrow evening, myself and some of the ladies within our executive team are hosting a virtual discussion on women's safety at work. And we're doing this following the sad case of Sarah Everard. I've already had quite a few emails from staff within the organisation, male and female, actually talking about car parking. So I think we've got quite a lot to do on car parking, not least that it's free, which is really good news for the next year, but also about where people park, and especially when we start getting through winter and dark nights. So really pleased to hear that. I think the second point, which is quite brief, is I think we know as directors that generally by the time information gets to us, it's often quite filtered. So being able to touch everybody within the organisation is really important. And of course, we're not going to be able to touch 5,000 staff, but we need to be able to have our immediate managers and teams being able to have those open conversations. So again, I think that's a really good point of part of our people plan. Thanks for that, Mark. Thank you.
Okay, thanks for that. Lisa?
Yeah, my question was how we're going to share this with staff so they hold us to account and really understand actually what our ambitions are and what we plan to do, which kind of builds on Trevor's about holding us to account for delivery.
Thank you. Alice?
Yeah, it's just to follow on from Trevor's point about do we need an IGR for the people plan? I think there's a wider point as well of what do we need reporting and metrics wise on all of these group strategies and initiatives that we've got going on, that we need to think about how they're reported. So they're not reported in 6 different ways to 6 different committees. And there's a huge burden there, but how we can do that most effectively and who needs to see what parts of what reports. So I don't know the answer, but I think it's a bigger issue than that actually, but I agree that we need to get that sorted.
Okay, I think that's helpful. It sounds like a little bit of work for CPC as well to oversee. I've already talked about your burden.
Sorry, Anna, I've lost you there, but should I answer?
Want to respond to those, and then we'll go to Simon.
Yeah, of course. So in terms of sharing this with the staff leaders, you're totally right. It's a two-way street. So staff need to see what we're trying to put in place and operate from a corporate perspective, and equally we need to see that this is being owned and actioned locally within not just divisions, which is even still perhaps even too broad, departments and service areas and so on and so forth. This is the expectation. This is what we offer, and this is the expectation in terms of how we expect people to behave and interact with one another. I think there's a jewel around that, and how we communicate is going to be so important, and that is why I'm so happy about the communications team and the changes that they've been through in terms of making sure that's consistent across the group, and ensuring that we're able to create our communications so that we're continuously feeding the messages in from this people plan. So one of the things that I had in terms of one of the interviews for one of the recent senior leadership team within the communications team is in the interview they spent 20 minutes telling me about how poor our social media was and how it didn't have a story or a narrative behind it, and how we needed to create more coordinated messages as opposed to, oh, we've bumped over something, we should tell people about it, and so on and so forth. We have to talk about these themes and these pledges. We have to talk about people planning, people processes. We have to keep the language similar so people see there's a connection between one and the other, as opposed to using alternative or different language. I think people are pretty au fait now in relation to health and well-being, but we need to make that clear around people development instead of education, people processes, and so on and so forth. And I think ultimately the way people will continue to engage with a plan like this is when they see the benefits. So when they see, what does this matter to me, and is it having an impact on me or not? And some of those, they are multifaceted, but one of those, just in the most recent example, or more recent example over the next couple of weeks, is that we are taking our temporary staffing provision back in-house. And so will people see a better service on the basis that we are doing that? And that is obviously our hope. And then as we get to work closer with Northampton, will they have more opportunities available to them more easily to work across two sites? So that's just one. I mean, there's so many examples, but that's just one about how people have to see that we take the action and it has a difference and an impact upon them.
Okay, thank you. And last word, Simon.
The product of what we've got here today is hugely impressive. So I just wanted to say thanks to Mark, to the People Committee, and to everybody who has made what we've got here today a reality. It's been the product of a huge amount of people's labours, and it's right that we pause and reflect and acknowledge that work. 3 points on measurement, I think, from me, and then something on comms. So the first point, I think both Trevor and Alice talked about IGR and measurement. So firstly, formally, we have committed to reporting progress on this strategy within 6 months. So the board will formally review our progress on it in that period of time. But clearly, that's not enough. As people have acknowledged, we're going to need to develop a far more contemporaneous version. Mark used Pulse, so some people will be familiar with the Pulse type surveys. And one thing I wanted to say, so I don't know precisely what we're going to do, but we need to get on and do it sooner rather than later, because the data that we're looking at in the staff survey is October last year. So, you know, who knows what people are feeling now. We need to be able to capture that data far more contemporaneously. And I'd say it's not just for Mark as the Chief People Officer, it's for us all to own it. So, you know, we already know, those of us sitting around this table, where some of the groups are who feel less connected to the organisation than we would like. And I talked earlier about the need to go and have conversations with those people, but we also need to start talking about that. So how are we, just to pick 2 random groups, talking to the staff who work for us in the digital domain or the estates domain or the domestics domain? You know, people who are at the front line of our services in so many ways, but who probably feel less connected to the organisation than we would ideally like, if we're honest. And we need to try and work out what's going to work for them. So I'm just commending to the board that notion fairly early on of the Pulse survey. And all of us taking an ownership stake in that. We've all got opportunities to do that through our portfolios. There was a wider point made about the group, because the strength of this plan is obviously it's not just a plan for Kettering or a plan for Northampton, it's a plan for the group. So there's something about thinking, how do we get, and I don't know the answer to this sitting here right now, but how do we measure the benefits that we are looking to accrue at a group as well as at an individual hospital site level? And finally, no pressure, Teresa, if you're listening or watching this morning as our incoming Director of Comms, but how we get the message out there is probably a big challenge for us. Mark's acknowledged, that's a big challenge for us. And I think we could do well as a board, either in development time or in kind of formal time, when Teresa's arrived and got her feet under the table, to actually listen to how she thinks we ought to be reaching out and talking to our staff in a far more structured. I think it would be good. We haven't actually done that, as far as I recall, in a systematic way. So I'd commend to us all the kind of notion of actually spending time thinking about the messages we are getting across and how we do that. Thanks, Alan.
Okay, anybody else at all? No. Okay, this has been through both boards now, and both boards have said very similar things about it, as you might expect, slightly different, but very similar. I think, Mark, we can all agree that the board thinks this is a very impressive plan. The board boards, plural, have great, and the committee, the joint committee, have great confidence in your ability to deliver it. Good. And but it is worth thinking about the fact it's got to be delivered at the micro level as well as the macro level. It's got to happen to every individual down there. And so let's not forget what we've got to do with your team to deliver this as well. The investment of leadership and time down through your team. It's a long time since we had the joint people staff meeting at Highgate House, which was a kick-off. And again, COVID has got in the way of a lot of things. But let's not forget that to deliver this, there'll be a lot of other parts of the organisation, including your own bit, that has to be developed and worked on. But we're very confident that this is a very strong plan, and very confident in the committee and your leadership to take it forward. So thank you very much for that. Thank you for the effort. It's had a long gestation, but it's got here. So thank you very much. Andy, we're on digital strategy now. We had a very good meeting with NHS Digital, which was part of the deal, or NHSX, which is nearly the same thing, with which Alice joined, as well as Simon and Andy and myself. And I think it was an extremely good meeting. They were full of praise for us. And they actually, I think, used the phrase, we'd now like to call you one of our hero trusts. Mr. Callow occasionally points out to me he's on the top 50 list of CIOs as well. So this strategy is all looking extremely good. Other people not yet on national lists, please pay attention. Andy, over to you. Digital strategy, it's looking extremely good. Please take it through. And just for the purposes of Richard, may I think, yes, Richard, the plan is confirmed from the previous agenda item. Okay, Andy.
Thanks, Alan. Yeah, so this strategy has been through the various committees, and Mark and I have been following each other like the worst kind of double act. So what you have before you today is the final version for your approval. And this is accumulation of lots of effort, feedback and energy from people across the trust and indeed the public. But before I go into the strategy, I'd like to take a moment to look back. And I think what Alan just said around the meeting with Matthew Gold gave us an opportunity to say what has happened in the last 12 months that we can be proud about. So if you think about that, we've enabled our staff to work from home. We've enabled video consultations and extended virtual consultations in general, and we introduced virtual visiting, which has been a real success. We've kept the basics going, so we've maintained our cybersecurity defensives. And then we think about our COVID vaccination response. Our internal software development team created an in-house vaccination booking system used by the Mass Vaccination Centre in less than 2 weeks, and that's still in use today. One of our Chief Nursing Information Officers won the Digital Leader of the Year in the Women in Tech Excellence Awards. And we were the first trust in England to publish our Cloud First policy, which is actually followed up by us being selected to be a national exemplar in cloud acceleration by NHSX. A couple of weeks ago, we did a Love Digital Week at Kettering. And thinking back to June 2020, we did one morning. And this year we had enough to fill a week, and there was some really great things in that week to sort of celebrate what's been happening. And also, unlike many trusts, we've continued our electronic patient record program. So all the non-urgent referrals are now electronics. All inpatient wards have live electronic whiteboards, and EPMA has been rolled out, and discharge summaries are now electronic. So that's brilliant, and it is worth taking that moment to celebrate. But let's not forget, despite this, by external measures, we'd still be classed as digitally immature. We've a long way to go, and what you have before you in the strategy is the ambition to get us there. And you could describe it as our moonshot. This is our set of audacious goals. And simply put, we don't know how we'll get to the end point on some of them, but based on what we've done so far, I'm really confident of progress. So as well as the targets and various themes in the strategy, we'll hold ourselves accountable to external measures and use the HIMSS assessment as a benchmark, and we'll aim for the top level. And I'm not aware of any organisation that's made this many HIMSS steps from where we are now to the level 7 in 3 years. There's also an emerging what good looks like maturity standard that I've been part of developing with NHSX colleagues, and my aim would be for us to be ranked #1 on this. But that's all well and good, the external measures. But I want our group to be in a position where we're the go-to trust to understand, that people understand that we're the place that does digital transformation, that we deliver excellence to our patients and staff. And being the most digital hospital in England will clearly put KGH and NGH on the national map. And I see we'll gain accolades through the NHS because when we say we do something, it happens. Our clinicians rave about the software and kit they have. Patients give us excellent feedback about the digital services they use, and our teams recommend our trust as a great place to work and develop their careers. So how will we make that happen? So firstly, you'll see in the strategy a core set of principles that we'll monitor ourselves against. And probably the only one I'll mention at this point is around focusing on user needs, because everything flows from that. If we really understand what patients, staff and clinicians need and put them at the heart of what we do, then everything else will flow from that. So working over the last few months with staff, the 8 themes you see have been adapted along the way, and they've been iterated. So I'm not going to go down the themes one by one. What I'd like to do is put that through the lens of what it will feel like. So for me, I think the key elements are about improving the patient experience. So many patients have told us they've not welcomed not battling with our car parks during the pandemic, and have felt assured through telephone and video consultations. And there's lots more we can do in this space. We want to give them better access to their record, increase access for monitoring remotely, control over appointment bookings for all system partners. And you'll see that's captured in theme 1. And we know that happy staff give great care. So the second thing is around the ambition in this strategy is to give people tools that they go beyond just coping with to loving them because it helps them do their job. And as well as doing all this new good stuff, we're going to make sure that the foundations are sound by ensuring universal connectivity and access to amazing support and training. And you'll see that built in theme 2 and theme 3. If you think about what our clinicians have access to at the minute, frankly, they're blind to a lot of what's going on. And we need to recognise that a care journey crosses many settings, of which KGH and NGH is just one. If we only see the partial view, then our service to the patient will not be as good as it could be. So moving to a group electronic record will start to address this, and you'll see that in theme 4 and theme 6. And we've talked about it earlier on, haven't we, about our elective recovery, about using data to improve care. And our paper records can't be analysed to deep dive into outcomes currently. And as we grow our electronic record, we'll have more capability to review outcomes, assess performance and compliance, review pathways and processes. And you'll see that in theme 5. And finally, giving back time to care. We have over 220 clinical systems across our group, 100 corporate systems, and many of them overlap in functionality, and very few of them join up. Every single one of them has an overhead in training, in support, in cost. And so moving to consolidate these systems and integrate them into the electronic record will help staff to have that consistent experience as they move between both hospitals and give back that time to care. So you'll see that in theme 7. So colleagues, what do I ask from you? Primarily your support in the delivery of this. And this strategy isn't about something that just happens in one corner of our trusts, and it's certainly not just about me. To really benefit patients and staff, digital transformation will impact all areas and require us all to commit to this. And frankly, at times it won't be easy. For example, moving to a group EPR will be a potentially bumpy ride. And so I'm asking for us to stand shoulder to shoulder during that time. And sometimes we'll feel worse before it gets better, but the prize will really be worth it. So in finishing, colleagues, I hope you'll be able to approve this strategy and help us take the next steps towards our digital future.
Thank you, Andy. Anybody comments, thoughts, or supportive words? I'm not seeing anything immediately. Well, yes, I am, as expected, really. Lisa, then Alice, then Simon.
Sorry, I thought I'd got in after Simon. That's fine. Andy, you know I'm a fan of this strategy. I think it balances ambition and will make a real difference to patient care. Because for many patients, actually turning up at a hospital is something they don't need to do. They can have their follow-up digitally. I think the only caveat I would say is, I think national surveys say about 77% of people are digitally accessible or accessed, which is not a reason not to do it. Because actually, if you started anywhere with a 77% capacity, you'd be, in many areas you'd be going, that's brilliant. It's just so we do have to think about that minority group for whom digital isn't the answer. And the other thing I'm really keen to progress is how the hospital EPR links into the Northamptonshire Care Record, which is in there. And again, you know my views on that. So that allows consultants to see what patients think is important and also what's happening in primary care. So we start treating patients as residents holistically rather than just somebody receiving an orthopaedic service. But brilliant, really impressive.
Okay, thank you for that. Alice.
Yeah, sorry, I was just going to also endorse the strategy. Obviously, it's been through the digital committee a number of times. The other thing I thought was just worth flagging, given we're here with a KGH perspective strongly this morning, is that we had a really useful session with the KGH governors as well, where we took them through this. Myself and Andy talked them through it, and I think they were positive. I think the one thing that came out from that, which is something I definitely think that me and Andy need to reflect on, links into Lisa's point around engagement, and they asked some quite probing questions about how many members of the public and patients we had engaged with. And whilst we have done that to date, it's been with relatively statistically small numbers to date. And I think there needs to be some real strategic thought into how we, along with our ICS partners, most fundamentally, look at engaging and taking the population with us on this digital journey. So perhaps, hopefully that 77 goes up to some extent. And even if it doesn't, how do we deal with general literacy and comfort in using some of these tools amongst our staff and amongst the population?
Okay, thank you very much. We'll go to Trevor next.
Thank you. And again, I fully support the strategy. I suppose my question is, do we know, and I'm looking both at Andy and Neil here, that we have sufficient resource to be able to actually meet these targets, or these aspirations, because resource is tight. It may even get tighter. So how are we going to be able to do this in the current economic climate?
Okay, Andy, do you want to respond to those 3 points before we go to Simon? Or
Yeah, thank you, Alan. So yes, certainly the digital divide is something that's real and we need to be aware of. I think the approach will certainly be there's always an alternative route to a digital approach until it becomes no longer necessary to provide that, and I think that's really important in a way of doing it. Certainly on the NCR element, it's a key pillar of one of the themes as we grow our electronic patient record, more of that information will be available in the Northamptonshire Care Record, which, if you recall, the patient story that we heard a couple of months ago was around a patient who went through various settings and didn't have that information. So that will be enriched. I think it's also worth reminding colleagues that actually the Northamptonshire Care Record is a building block that will then interface to the East Midlands Share Care Record, and then that becomes part of the national picture. So this is very much a step towards having that much better visibility to make sure that clinicians have the full picture when they're dealing with a patient. So I think, just picking up on Alice's point around the patient engagement, certainly as a result of that, we've committed to look at that again, and I think to look at that at a system level is really important, and it will tie in with the communication to citizens around the Northamptonshire Care Record. I think it might be, Lisa, one of your one area that you'd pointed me at is actually they'd sent out messages to their citizens in the council tax bill, informing them about the share care record, and so using various different methods as a system to communicate to people around what's happening. We need to sort of use all the tips and tricks that are available. Trevor, to your point on the resources, so I think there's a few challenges ahead. So certainly around the group electronic patient record and getting the business case for the Northamptonshire, the Northampton EPR over the line is still something that we're sort of working around the affordability on it. I think in terms of the other ones, we'll take a business case approach, but I think one of the things that actually makes us one of the rare hospitals in the country is actually we've commenced this journey by putting our hands in our own pocket, and certainly Matthew Gold was very impressed on that, and also contrasted that with a number of other hospitals that are kind of waited till there's some national funding available in order to do this. And I think the message that we were able to give to him is we consider this so important that actually we just need to get on with it, and actually the benefits are there. I think the other thing to note, Trevor, is I think I am confident that as we build our reputation as a hospital group, some of this other funding will materialise. So I point at the two examples that I've said today. The cloud acceleration funding, there was £1 million that arrived at KGH towards the end of this year for that, and around 800k that came to Northampton for the robotic process automation accelerator. So I think we do good stuff, and that helps us generate momentum around the place. So I'm not saying it's going to be easy, but there's plenty of scope to go at.
Thank you, Andy. Okay, a quick word on Neil and then finishing with Simon, please.
Yeah, just going to add one thing. Again, Andy and I have been talking about financing in a range of ways. I think one of the other things we are looking at is how do we look at the national view on mechanising, finances from revenue and capital, and how does that work going forward, which is very different from where the traditional methodology of investment in capital has been. So that's something we're also raising at a regional level and hopefully back to a national level, which will support the agenda going forward for not just us, but the national, all the trusts across the country as well. That's something we're also picking up.
Thank you very much. Finally, Simon.
So firstly, again, thanks to Andy, and just again to say it's true, isn't it, that if we see further, we stand on the shoulders of giants, and Andy's got a great team who work with him and have helped him produce the documents today. So plaudits, I think, if you wouldn't mind, Andy, to them. Three quick thoughts. The first, I completely agree, Andy, with your point about shared care record. And if we link back to the discussion we had at the top of our meeting today, where Faye was talking about super stranded patients and our ambition to get that down from its current level, I think of 70s into 38. I think the challenge as we move into the next phase of implementing the digital strategy will be to make it really live in terms of some of the clinical outputs that we see. We're doing this because, not just because it's going to help us in terms of treat patients, it's actually going to improve the outcomes we get. And I think we need to think about how do we assign markers to some of the projects that we have that are actually clinical markers and start joining up the dots in those places. And I think the shared care record is a really good one, because the reason why we've been going after the shared care record like the Holy Grail for all these years is because theoretically it allows us to take better decisions for patients, not to admit them to hospital, to get them home quicker because we know what's going on. I think the premium around, I've talked about it already, and I completely commend Richard's point, but just to say I agree with it. We need to reset our aspirations around the IGR and the BI that sits behind it, so reset the metrics. But more than that, I think we need to be challenging ourselves to say, to use data to really make some of the decisions that are really critical to the organisation about where can we further improve performance. I didn't mention it this morning, but in the context of elective recovery, one of the things we're going to be challenged to do nationally is to really, again, look at the productivity data that flows from GIRFT and what is that telling us about where we are already good or where we can still further improve, just to put a marker down about that's going to be a really important a topic of conversation in the months ahead. Final thought, just coming directly to the resource question. So here's the thing. If we'd have been talking about, if we talk about the NGH EPR only as a problem for NGH to solve, the answer to your question, Trevor, is it's going to be difficult to get it over the line in the kind of resource constrained environment that we've got. So we need to start thinking about a debate about how do we have, how do we deal with priorities that may manifest themselves in one place, in this case in Northampton, but actually be of such benefit to the group, we should think about investing in them jointly as a group thing, rather than just seeing it as an NGH versus KGH problem. I don't have an answer neatly to that, but I wanted to put it on the table because as the Finance and Performance Committees think about their joint agenda, I think we're also going to think about joint investments. It wouldn't have been logical in the old days to say KGH would support NGH's investment, but it is now, I think, the new logic of working together in a group. We have to find a way of having that conversation as well.
Okay, thank you very much, everybody. For those of you that were around and remember what the KGH digital team and resource and reputation was a couple of years ago, this is a genuine example of a sea change. So it is to be highly commended. I think I agree it's a moonshot, Andy, but we should aim high, and you know my adage, chairmen are never happy, so you have to aim high to make us even vaguely happy. Many moons ago, I was the National Implementation Director for the National Programme for IT, and somebody far more intelligent than I was used to say about this digital divide access question. You know, in the 1950s, we didn't say to people who had a telephone that they couldn't phone their GP because not everybody had a telephone. And we just need to think our way through this problem, because sooner or later, everybody will have a digital access gadget, for want of a better word. So you're right, we have to make an alternative routes available, but we really ought to drive the digital route as the model that will last, if you like. And I think too, when you're surveying people on this, I did notice some stuff from our governors about the business of what the public thought, but it's surprisingly few how many people needed to be statistically significant in a population the size of Northamptonshire. So I think we've done quite good work, but you're absolutely right. We should go back over it because the governors have expressed some issues there. So we should go back over our levels of our engagement. But I think people often think we need far more people to comment before we have a statistically significant number. It's not the case. Anyway, I'm sure we've passed the plan. I'm sure the comments in the chat box are clear. We admire it. It's an excellent piece of work. It is a moonshot. Nevertheless, we fully expect you to get us to the moon. So thank you very much, Andy. Good stuff. Okay, thank you very much, everybody. Item 10, Group Finance and Performance Committee for approval and the Quality and Safety Committee terms of reference for approval. Can I take those as approved? Yes, I can. Good. Thank you very much. So those are both approved. It's time for questions from the public received in advance. I don't think we have any. Richard or Richard? No, we do not. I'm opening up for any other business. Thank you, Janet. Any other business at all? Anybody? Yes, Trevor?
Just one. This morning I awarded Tracy Lynch the Freedom to Speak Up of the Year award for last year. I just thought it would be worth noting that in the minutes of the board, after all her hard work in terms of not just with individual cases, but actually taking forward freedom to speak up with colleagues in the trust.
Where did that award come from, Trevor?
It's an annual award for freedom to speak up within the trust.
In the trust, right.
So I made the award this morning before the board meeting.
Okay, thank you. Oh, there we go. An award, right. Thank you, Richard. Now I can't see people, of course, but anybody, well done on that. Any other hands up that I can see at all? No. Just to reiterate, I think Debbie mentioned it in her report to congratulate Ian Roddice on his appointment as digital director. It's all part of the sea change in the digital offering and the digital reputation of Kettering. So that's also excellent. There we go. I think we're done. Can I ask you to pass a resolution to exclude the press and public on the basis of the private nature of the business to be conducted? Yes, good. Thank you very much. So that approved. The next joint development session with Northampton is Thursday the 29th of April at 10 o'clock, and the next public board meeting is Friday the 20th.